de graça fica mais lindo por causa do amor, por causa do amor, por causa do amor, por causa do amor. Um cantinho, violão, esse amor, uma canção pra fazer feliz a quem se ama. Muita calma pra pensar e ter tempo pra sonhar. Da janela vê-se o corcovado, o Redentor e lindo. Quero a vida sempre assim, com você perto de mim até o apagar da velha chama. E eu que era triste, descrente desse mundo, ao encontrar você eu conheci o que é felicidade, meu amor. Cantinho, violão, esse amor uma canção pra fazer feliz a quem se ama. Muita calma pra pensar e ter tempo pra sonhar. Na janela desse o corcovado Redentor lindo. Quero a vida sempre assim, com você perto de mim até o apagar da velha chama. E eu que era triste, descrente desse mundo, ao encontrar você eu conheci o que é felicidade, o que é felicidade, o que é felicidade, meu amor. Les yeux qui font baisser les miens, un rire qui se perd sous sa bouche. Voilà, les portraits sont et tout. Vélan auquel j'appartiens. Ah, c'est un des trois et quand il me prend dans ses bras, il me parle tout bas. Je vois la vie heureuse. Il me dit des mots d'amour, des mots de tous les jours. Mais moi, ça fait quelque chose. Il est entré dans mon cœur, un grand pas de bonheur, quand j'ai tourné la cour. Et lui pour moi, moi pour lui dans la vie, qui fait la vie, la juré pour la vie. Et dès que je l'aperçois, l'ange sur moi, mon cœur qui bat. Des nuits d'amour plus finies, d'un bonheur qui prend sa place. Des ennuis, des chagrins s'effacent. Oh, 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 oh. À nous mourir. Un, deux, trois, et quand il me prend dans ses bras, il me parlait tout bas. Je vois la vie heureuse. Il me dit des mots d'amour, des mots de tous les jours. Mais moi, ça fait quelque chose. Il est entré dans mon cœur, une grande part de bonheur, dont je connais les causes. C'est toi pour moi et moi, pour toi, je la vis. Mais la vie, la journée pour la vie, et que je l'aperçois, alors je chez moi mon cœur qui bat, mon cœur qui bat, mon cœur qui bat. Good morning and good afternoon, ladies and gentlemen. It's a very pleasure to me to be here once again in the 13 Retinawesome, and I think some Brazilian songs, bossa nova, and now a standard of the jazz, of the music, popular music in the world, La Vie en Rose, and now I will sing a song that Dr. Nakamura likes. Let's go. Penso che un sogno così non ritorni mai più. Mi dipingevo le mani e la faccia di blu. Poi d'improvviso venivo dal vento rapito e incominciavo a volare nel cielo infinito. Volare, oh, cantare, oh, 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 le lu, i piccoli lu, felice di stare lassù. E volavo, volavo, felice più in alto del sole ed ancora più su, mentre il mondo pian piano scompare negli occhi a tuoi blu. Una musica dolce suonava soltanto per me. Volare, oh, cantare, oh, 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 e lui, i figli di lui, felice di stare lassù. Ma tutti i sogni nell'alba svaniscono perché quando tramonta la luna di furta con te. Ma io continuo a sognare negli occhi a tuoi belli, che sono blu come un cielo trapunto di steli. Volare, oh, cantare, oh, 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 del blu, dipinto di blu, felice di stare lassù. Qui continuo a volare felice più in alto del sole ed ancora più su, mentre il mondo pian piano scompare negli occhi a tuoi blu. una musica dolce suonava soltanto per me. Volare, oh, cantare, oh, 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 nel blu, spirito di blu, felice di stare lassù, nel blu, spirito di blu, felice di stare lassù, volare, oh, cantare, oh, 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 nel blu, spirito di blu, felice di stare lassù, vedi, vedi gli occhi azzurri blu, felice di stare qua giù.
And just that let you know that you were my professor and also science professor at the University of Toronto. And we missed that time a lot. And it's an honor to be here again for this meeting. And to have you as a keynote speaker once again. We have much and lots to learn from you. And I also want to thank Pablo Sibiris, Dr. Ashraya Nayaka, Dr. Athanasius from Greece, and Vaibhav Sethi, Gabriel Diaz that just presented us some interesting music over here, and everybody else. And also Saad, Dr. Lam, and I want to ask Dr. Lam if you could possibly start your presentation, but before starting your presentation, you could give us some words on vitreoretinal surgery and your experience in the field. Thank you very much, and welcome again, Dr. Lam.
I think it may not be anything new for everybody, but it was, the way I look at it is that maybe a good refresher for everybody. And I think part of the Retinawesomes is to share different surgical ideas and try to get discussion among us to improve our surgical approach to the different problems. Okay, so I'm going to proceed. So subretinal hemorrhages is hemorrhage that accumulate between the neurosensory retina and the LPE. The cause are listed here. In Hong Kong, PCV probably ranked one of the top one. And with PCV, you tend to have a larger amount of subretinal and sub-RPE hemorrhages. The issues or the problem with the effects of submacular hemorrhages, you can have a direct damage to the photoreceptors from the clot formations at the very beginning. And also the byproduct of the blood, the hemosiderin deposit and the iron toxicity causing the oxidative stress to the photoreceptors and leading to apoptosis. There's also the physical barrier caused by the blood that block the actions of the LPE pumps and the nutrient diffusions. That is the earliest damage from the subretinal clot. Over time, you get severe degenerations of the outer retinal layer and the photoreceptor and the LPE layer that can lead to scarring of the LPE. And the prognosis usually depends on the size of the hemorrhages and the duration of the hemorrhages. The strategy for the treatment of these submacular hemorrhages is to displace the blood from the fovea and to lyse the clot and to treat the underlying choroidal nevus membrane with either anti-VEGF or photodynamic therapy. To lyse the clot, you can either give intravitreal or subretinal TPA, and that for the displacement, we'll go into a bit more, but most commonly you can use expansile gas injection to displace it if one chooses the pneumatic displacement. And importantly, the earlier the treatment, the better the outcome. And the study has shown that patient treated less than 14 days of the clot has better visual outcome than those waited for more than 2 weeks. So here are some of the treatment options. If the hemorrhage is small, observation can be done to wait for the blood to clear and then treat the underlying choroidal nevus membrane. If the blood is thick enough, then you can either use pneumatic displacement or with intravitreal TPA. And another option is to use subretinal TPA. And for the very large clot, you can also actually remove the clot from the subretinal space. And then in some cases, you can also remove the choroidal nevus membrane. And we are all probably familiar with the tissue plasminogen activator. And what it does, it converts plasminogen to plasmin. It helps to facilitate the lysis of the clot. And as described here, the earliest, the better to create this kind of lysis or changes the fibrinogen to the fibrin so that it can be able to degrade faster and more complete. And there are a couple of approaches. You can either give it subretinally or intravitreally. And with the subretinal TPA injection, there are some related complications, such as causing macular hole formations if you inject too rapidly, or if for this procedure, you need to also do vitrectomy. So technically, it's more challenging. While the pneumatic, using intravitreal TPA, you can use it in combination with pneumatic, and it can be done in the office. But some of the problem is that you can get breakthrough vitreous hemorrhage, which may end up having the patient needed vitrectomy to remove the hemorrhages. So how does the intravitreal compare to or subretinal TPA? In fact, study basically shown they are somewhat similar, and different studies have shown the similar outcome between the pneumatic displacement versus intravitreal TPA, and they are not particularly seems to favor one over the other. However, most people these days will prefer intravitreal TPA because it does allow a more complete displacement of the hemorrhages. And we already mentioned some of the treatment options, and so I'm going to skip this slide. So I'm going to show you a couple of cases and discuss some of the salient point of the management. So I have a 75-year-old gentleman with history of hypertension, been on aspirin, and because of the ischemic heart diseases, he presented with a sudden onset of decreased visions with a central scotoma and poor visions. You can see the clinical picture showing a submacular hemorrhages and with some pooling of the hemorrhages in the inferior arcade. The OCT was quite telling. You can see there are quite a bit of subretinal hemorrhages underneath the fovea with some fluid. In addition, there's a small pigment epithelial detachment and not much blood in the pigment epithelial detachment in those cuts. So the thought is that the hemorrhage is probably too big to just do a pneumatic displacement. The patient was agreeable to vitrectomy and subretinal TPA and gas injections. And postoperatively, you can see the visual acuity has improved from count finger to 20/70. and the patient was subsequently treated with intravitreal aflibercept. You can see the preoperative pictures and the postoperative pictures. So this is what we are very used to see if we manage the patient this way, and you can get a very successful outcome of the displacement of the hemorrhages and improvement of visual acuity. And let's go on to another patient. This is a 78-year-old woman, somewhat similar history, also on aspirin, which put them at a higher risk of larger bleed. In fact, this patient has a very large bleed. You can see on the Optos picture, compared to the last patient, this is huge in terms of the hemorrhages. And preoperative OCT show very extensive subretinal hemorrhages. In addition, there's also evidence of sub-RPE hemorrhages. And you can see on this OCT cut is component of subretinal hemorrhages, and they are component of sub-RPE hemorrhages. I'm going to show you the intraoperative pressure, intraoperative movie. And we also, in this particular case, we were able to use the intraoperative OCT to guide us for the surgery. And you will see the benefit of having the intraoperative OCT. So here's the surgery. You can see we start off doing the core retractor, clear off the peripheral vitreous. And I want to pause here. With this large hemorrhages, I thought perhaps maybe I will create a larger detachment and may do the subretinal excavations of the clot. And because I didn't think doing the subretinal TPA will be sufficient to displace the clot because the clot's so big. So you can see the extensive subretinal hemorrhages, the fovea there, and there are also components of the sub-RPE hemorrhages. You can see that on the OCT. Just going to go back just a little bit. You can see on the intraoperative OCT, there are two components. This is the sub-RPE hemorrhages, and there are some of the subretinal hemorrhages. So I start off injecting the subretinal fluid through the 41 gauge cannula, try to create a detachment. And what I found is that the bleb doesn't really extend very periphery, but it runs into the subretinal clot. So I decided perhaps maybe it would be better just to go ahead to inject into the clot, and instead of trying to do my original thought of doing the excavations of the subretinal clot because my original plan was to do a temporal retinectomy and flip the retina and remove the clot. What's important, or what's useful at this time using the intraoperative OCT, is to try to avoid the injections of the fluid with the TPA into the sub-RP, the RPE detachment, or the underneath the RPE, because there are multiple sub-RPE hemorrhages in the vicinity of the hemorrhages. So the intraoperative OCT will help to guide the injections of the subretinal fluid. And here you can see there's the subretinal fluid where the blood is mixed, and adjacent to it is the RPE detachment. So what I did was to create a more bolus detachment there with the subretinal TPA. And realizing there's a lot of blood that's there, and if in the usual case I would just stop there and do a postoperative positioning and to allow the blood to move inferiorly. But concerning with that amount of blood, so I decided to do a small retinotomy to drain the subretinal hemorrhages to make it easier for the blood to absorb postoperatively without having a large amount of blood inferiorly. So you see next there is endodiazepam made at the very temporal border of the serous the detachments of the retina. So heavy fluid was injected to displace the blood towards the retinotomy. You can see that the blood at the macula is clearing. There's only this exudate at the macula, and the blood is escaping through the retinotomy. And so we just clear up the blood, and you can see centrally at the macula there's less blood already. So so by removing the subretinal blood, it allows the reattachment better, and also you don't have to have all that inferior blood, inferior displaced blood that could potentially cause fibrosis postoperatively. So just a little bit more drainage of the subretinal blood that escapes through the retinotomy. And once the all the subretinal blood is clear, you can see there's some residual sub-RP hemorrhages and some residual inferior subretinal hemorrhages. And the OCT, intraoperative OCT confirmed the presence of the those blood that was there is sub-RPE and not subretinal. So I don't need to concern with that. And now I just laser the retinotomy and gas fluid exchange. So some of the issue that need to be considered using the subretinal TPA and this approach is that there are the potential toxicity, and I think study has confirmed that at 12.5 microgram in 0.1 cc of TPA is well tolerated and has very minimal complications. And vitreous hemorrhage are not uncommon to occur either as a breakthrough hemorrhages or just having the surgery. One of the things that one needs to be concerned with is the risk of RPE tear or macular hole formations that usually result from a very rapid injections of the subretinal fluid, or if there is a attenuation of the macular hole. And I'm going to show you one of the case that during the injections of the subretinal fluid, you can see that the macular hole was formed with the blood escaping through the macula. And if that happened, I don't think you should just quit. I think that you can still proceed with the surgery and create went on to your original plan, create a bleb elsewhere, and then and just completed the surgery, and you can deal with the macular hole subsequently. I usually don't try to do IOM peel at this point. I would just manage the patients first with the displacements of the hemorrhages, and then deal with the macular hole in a secondary surgery. So this is unfortunately is one of the complications related to the surgery that we deal with. And how do you minimize some of the complications? Of course, you know, knowing your equipment and knowing the control is best, and reducing the number of retinotomy will also be a good means of avoiding the postoperative complications. And sometimes it's probably better to start the bleb outside the hemorrhages so that the fluid dissect into the detachment, so that you don't have such a sudden gush of the fluid, and avoid forceful subretinal injections. And one thing I find that is helpful is to look at your rate of the fluid injection outside the eye before you started the case, so that you have a better control of how much fluid being injected in the subretinal space. So once you kind of control, have a better understanding of the rate of the fluid being injected, then you can go on to do the procedure without having the potential risk of creating the macular hole. And by injecting outside the clot, the fluid will slowly move into the clotted area, without having rushing into the macula and create a macular hole. I think this due maybe a little dark, so you may not able to see what's going on. Let's see. Yes, you can see the fluid start to dissect inferiorly in this case, and the macula is preserved in this case. Again, the key is injecting outside the clot itself, because inside the clot there are not only the clot, there is a detachment that was there already, and you can see with the continued injections that you get the detachment that's occur without having the complications of the macular hole. Okay, I think that's the end of my presentations. I'll stop sharing, and I would welcome discussions from everybody, because I think all of you probably have to do this one time or another to manage patients with submacular hemorrhages.
Well, that was a great show that you gave us today. I think the most important thing that I showed, that I'm telling everybody and nobody understands that, subretinal injection with a tiny tip of 40 increases the speed of the injection, because, you know, it multiplies. The smaller the lumen, the forcefuler and the more intensive is the injection. And the tip that you showed us, that you should do it outside. But how do you inject this thing? Do you inject it by foot pedal? Do you inject it with your finger, with a syringe, or how do you inject beneath the...
I use the foot pedal using the VF, the viscous fluid injector to inject, and I usually turn down the injection pressure down to about 16 to 20, and I gauge it through the outside to see how rapid the fluid goes. And the rate that I like is what I've shown you, is that kind of not a gush of fluid rather than a steady flow of fluid. And this way, there won't be a sudden surge of pressure through the subretinal space.
You mean continuous injection or just one rapid one?
Continuous. I usually push my pedal and have that kind of drip, 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 drip kind of appearances of the float, and so it won't be very rapid. And it is a linear.
Go back and forth. Do you go back and forth? I mean, you stop for a little and then you re-inject. You stop for a little and then you re-inject, or you do it in one step.
In one. Okay. And in fact, I found it more helpful if you start the injections already before you puncture the retina. So the minute you puncture the retina, because you already have fluid injecting, you create a blood right away. If you push the cannula to the retina, and there's a risk that you puncture the RPE as you inject. So this way, if you injecting while you enter the retina, the fluid actually pushes the RPE away and reduce that risk of sub-RPE injections.
You know what I've done for you?
Yeah.
We're organizing a bionico eyes, artificial bionico eyes, by Andres Bernal, who's doing this, to have subretinal blood and do injection when you come to the TBRS in July.
Sure.
Do show us how to do the injection on this. And it's the first time we're going to have a subretinal hemorrhage in a bionico eye.
Wow.
And we consider you as the teacher of that.
Well, thank you.
Try to have some vacations in July, and don't use all your vacations.
We'll do. Well, looking forward to it. I think it will be quite an experience. I haven't used the bionic eye for subretinal, so this is new to have that blood.
The first time we have this new, and we can try the injections of subretinal injection for the macular hole system. Karsten is coming from Germany to show us how to close, the Canadian way.
Yeah.
Okay? Carsten is picking up from Germany now, and he's coming to show us how to do it in an artificial eye. And I think it's going to be very interesting if we can succeed to do it.
Perfect. Well, thank you. Looking forward to it.
Very good surgery, Dr. Lam. And
Hassan, you have to unmute yourself.
Very good surgery, great approaches. And
Dr. Lam, can I
Sure.
ask one question?
Yeah.
First of all, great lecture as usual. My question is, what do you think of doing multiple injections, and what about subretinal air? Is this something you would advise?
That's actually very good questions, and I think as one of the pros, you should minimize the number of punctures if you can. So I think when you push your needle through the retina, when you create your first bleb, you should stay there as long as possible. One of the key to be effective is to try to hold your hand steady, because if you start pulling the camera back or you start to wobble, it will create a larger retinotomy. The fluid will escape. But I think it's fine to create a second or third puncture in order to make the subretinal bleb as large as possible. You have to have the bleb included the entire subretinal clot, so that postoperatively the clot can migrate inferiorly. So I think that's the important aspect of making the kind of macular detachment with the subretinal injections. So it's okay to make more than one, but I think the key is to try to keep the injection steady, so that you can have one large bleb at a time.
What about air? Some people inject subretinal air at the end of the procedure. Is this something?
Yeah, I have. In fact, the last case I show you, that the air were added to the end of the case. I think this is a quite clever idea proposed to have the air, subretinal air put in, so that you get a better displacement of the blood in the away from the fovea and inferiorly. The important thing is that don't overdo it, meaning that you just want to add the air bubble that takes up no more than half of the subretinal bleb, and so that this way the displacement be sufficient, but you don't run into trouble with the subretinal air kind of ruptures through the macula or creating other complications.
Sir, I have a question. Can I ask?
Sure, please.
So this is Dr. Ashraf from India. So
Yeah.
a wonderful presentation, really awesome videos, befitting for Retinawesome. So just a couple of things. In India, we also get a lot of PCV-induced submacular hemorrhage. So when I personally feel the vitrectomy in PCV cases is slightly more tricky than in conventional cases, and sometimes you might have iatrogenic breaks on table. So then you will have a lot of subretinal blood, then we can't attach the retina back. Then they can have continuous phases of recurrent RDs. How do you manage the case, and how do you, what is your trick to avoid these iatrogenic break in these cases? And do you feel the vitrectomy is a bit different in this case?
Yeah, I haven't run into any more incidents of iatrogenic break from PCV. I do agree, though, among the Asian populations, they are more myopes, and perhaps they might have more associated peripheral lattice or peripheral abnormal vitreoretinal interface changes that can lead to more peripheral breaks during the vitrectomy. That happened irrespective to whether there is subretinal or sub-RP hemorrhages. And the key is to identify all the bricks at the end of the procedure before you go to air, and then treat all those tears. The other important aspect of doing this procedure is to not create the bleb all the way to the periphery. You limit your bleb only to the area of the hemorrhages and slightly beyond that. And because if you have the bleb communicating to the retinal break, then you will run the trouble, as you mentioned, having a more extensive PVL and potentially more risk of recurrent detachment. I haven't have to use silicone oil as the primary tamponade for most cases. I usually prefer just gas, because these cases are usually not retinal detachment. They are subretinal hemorrhages. So, so I don't want to add another kind of complications to the management. So I would say do a very meticulous peripheral inspections, treat all the bricks, and limit your subretinal bleb to only to the extent of the hemorrhages and slightly beyond it, and not to communicate with those peripheral bricks. Then I think you can minimize those PVL complications that you mentioned.
Thank you, sir. Thank you.
Dr. Lam, I had one question, sir.
Sure.
One situation which I handled personally, the videos you showed were so great that it looks very easy to do those big macular hemorrhages. But when you actually do them, especially for the first time, you can actually burn your fingers, and those cases you remember forever. So I had a case some time back, an elderly lady who came with high pressures, 60 plus pressures, her anterior chambers were flat, and I did a B scan, didn't have any view, and she had massive detachment as well as subretinal hemorrhage. It looked like she was on blood thinners. So she had corneal edema, and so I did counsel her properly, took her up for surgery. And during the surgery, what happened is the plan was to inject subretinal TPA, 12.5 microgram, as you have explained very well, and later on create a peripheral retinotomy, trying to drain out as much as subretinal hemorrhage as possible, and then put in gas at the end of the procedure so that we can displace the hemorrhage. But by the time I did the vitrectomy, initially the detachment was total detachment. There was no space for me to find a proper place where I can where the retina was attached after the vitrectomy. I injected the TPA, waited for half an hour for it to settle down. But I think that was a mistake I made, because what happened was I injected in two sites, and after half an hour when I started draining the subretinal hemorrhage, most of it was still clotted. So then the problem was the view was compromised. I tried to debulk the clot from the retinotomy, and went into air, squeeze out the hemorrhage from there. Then I switched to plan B, creating a retinectomy. But by that time, the view was so bad that I actually had to close the procedure. And I was not able to, save that eye. And next day, the patient came with total hyphema and low pressures, and there was total vitreous hemorrhage also. So that was one case I still remember that can happen. So
I think what you describe is something that we all dread to happen. What you describe is something that we might run into, especially in the massive subretinal hemorrhages. And you identify several important aspects of the surgical management. One is that the longer the procedure takes, the more likelihood you get some limitation that sets in, such as corneal edema, which is probably one of the most common complications for the VR surgery, is that the corneal edema limited the visualizations of the posterior segment. As a rule, I never hesitate to debride the corneal epithelium in the case of corneal edema, so that I can see, because the epithelium will grow back, but if I can't see what I'm doing, then it will not be any good to the patients. In the case that you described with this massive subretinal hemorrhages, TPA I found it probably not very useful. And as I was mentioning, for the case that I was managing, I wasn't planning to use the TPA. I was actually planning to start off with create a posterior detachment and do a temporal retinectomy to remove the clot. In your case, with the total retinal detachment, that might be the options to consider, is that you may as well take advantage of that total detachment that you already have. Then after you complete your vitrectomy, do the temporal retinectomy and flip the retina over and excavate the clot, and not to worry about the TPA. And you use your cutter to remove the clot. That could have saved you that half-hour waiting, and because at the end you end up actually doing just that. Because I think trying to remove the massive amount of clot through a small retinotomy after TPA are not very effective. Not only that the clot may not be breaking up sufficient, is that you're going to have residual clot that actually impede or blocking the retinotomy that will limit your amount of drainage. I think if you bite the bullet and just go for the gusto from the very outset, that might have been a better approach.
Cool, Dr. Lam. Thank you very much for your really keynote presentation. That was awesome. I just want to tell you that Dr. Alexandre Ventura is here with us. You remember him?
Oh, yeah. I do.
You remember that I knew Alexandre Ventura when I visited Toronto for, I did my retinal fellowship there, and then I kept going every year for an update with you, Dr. Deveni, Dr. Berger, and Dr. Harvey. And one day I met Alexandre Ventura there. He's now at the beaches here in Brazil, at the coast. And I said, you should come in to say hello to Dr. Lam, because, he's down there in the screen, and he's very pleased to see your lecture as well.
Thank you.
I want to say thank you to everybody, also to Gloria Gamat that from Pi Magazine that joined us a few time ago, and all the residents from the iBank Foundation mostly are here watching Dr. Lam's lecture, and everybody else. And I would like to invite Vaibhav Sethi to give the next speech, because Dr. Sethi has another meeting on the way. So welcome, Vaibhav. It's good to have you here again. And as always, our meeting last a couple of months, that was great with Pen Ophthalmologica. Thank you again for showing up.
Can you make me the co-host, please?
One moment. Yeah, you are co-host now. I guess the sound, everything now is pretty better.
Still showing host disabled participant.
So, yeah, I think you are already allowed to be co-hosts. Yeah. Can you share your screen now?
Not able to share.
Yeah, he found it here. Just a second. Yeah. Okay.
Can you see my presentation?
Sure.
Yes.
Thank you. Thank you for this wonderful invitation, and it's nice to see everyone back and enjoy Dr. Lam's presentation. I'll be talking on a short video of my experience on how much to pinch the epiretinal membrane to prevent bleeding and maybe cause more bleeding. So epiretinal membrane surgery. So this was a 67-year-old female with decreased vision since a year. This was the OCT and vision was 20/60 in the left eye and was pseudophakic with a, as you can see, an epiretinal membrane. And I counseled her for a surgery and then directly jump into the surgery. So yes, so this was the epiretinal membrane you can see there, and everything else was fine. So I start routinely with a tricot to stain the posterior hyaloid, making sure that I get the posterior PVD, complete PVD. And this was a tough PVD for me because the patient had very strong adhesion of the posterior hyaloid. You can see that there was peripapillary hemorrhage while doing the PVD, which also indicates a strong adhesion. So after completing my PVD and extending it all across, like I thought it'll be a routine case, rest should be a cakewalk. And I was thinking of the next case that was happening already. So I injected my brilliant blue and this was the patchy island stain and the negative contrast stain after BBG dye. So I got some of the ERM out and it was coming piecemeal. Every single place was just, I was able to get small patches, as sometimes that happen in epiretinal membrane cases. And maybe I was getting a bit too overconfident in getting the peel done properly. And I was able to manage around the fovea. And this was a small island which I thought I'll just peel it off also. Oops. And that really led to sudden gush of blood, and my heart rate went up just like the patient's. And so what I thought, I'll just wait and just pray to God that I not cause a full thickness break there. So I just wait and let it clot and increase the pressure slightly. And then after getting back to normalizing pressure, I just aspirate with the fluid just to make sure that just aspirate as much as possible around that area. So there was a small strand there, pull it out. Then I did one more smart thing. I thought, I am done with it. Now I'll just remove this clot as well. Oops, again, the same mistake I made. I should have just left the clot there because that was a natural clog there, which should have just helped me out. So I thought, I'll just let it be like this. I'll just let it organize again, let the thing clot again. And fortunately, it was the parafoveal. And I checked the periphery, did a fluid exchange. And finally, at the end of the surgery, I just aspirated some amount of the residual hemorrhage. And at the end, just to be safe, I injected gas also, SF6 gas. So post the surgery, a month later, the patient's fovea was good, everything was fine. And this was the area that had the partial thickness break. I saw the OCT. The OCT fortunately showed me that there was a small partial thickness break. So I actually pinched a part of the lamellar tissue while lifting on the island. So the vision of the patient regained good vision. And so I realized a good lesson from this surgery, that it's better to just scratch and pinch what you think is right and maybe not do too much. I think I was already done with that IL-11 epiretinal membrane, which should not have gone more aggressive, and minimal tissue handling with maximum outcome is the key. And these breaks, bleeders are self-limiting. You don't have to, laser them in the macular area. Maybe just injecting, even air would have done the trick. I was just more cautious, so I injected gas. So that helped. Thank you very much.
Let me ask here, any of the fellows, do you want to comment? Henrique, do you want to comment on this case from VibeHab? Or maybe Alexandre Ventura, before Athanasios. Alexandre, are you having a good time in the beaches now, or you are able to speak a bit? If not, Athanasios, please comment on VibeHab's case, please.
I love to see young surgeons to use wide-angle observation systems for macular surgery. When I saw with some 15 years ago in the retina, everybody attacked me and said that there is no resolution. You can ask if what you're doing and you have to put a contact lens for that. But I love your presentation. but you're missing something. Your illumination, while you have a beautiful light inside the eye, you can see it. It was a 30 degrees illumination, not a wide angle illumination. This way, it's like you look with a flashlight inside the eye. While you have the whole view, you're flashing only the places that you're working at. I think we should combine wide angle illumination system together with wide angle observation if you have the access. I know that they're a little bit more expensive and they don't make them so much, especially Alcon. The second thing that I noticed is that you're doing a beautiful job touching and pitching, and later on, at the end of the surgery, this is the bread and butter. Retinal surgery now is bread and butter for the young fellows. You know that. I mean, you say, okay, I'll do it 10 minutes and then I go home. But I found out that later on, after a few months when you're happy, you see in the OCT some nerve fiber dystrophies, some areas that they are dropping down the vision a little bit. And they say it's atrophy. It's because you remove some pigment behind the eye. Have you seen, anybody of you seen in epiretinal membrane late atrophies in the area of the macula? That's the question.
All right. Thank you, Vaibhav.
I think you see it more often if an IOM is also peeled. If you just only peel the epiretinal membrane, I don't think that will happen. And it has been shown by the Italian group that you get this dehiscence of the nerve fiber layer over time after the IOM peel. And different groups have shown nice and on fast OCT postoperatively after the IOM peel, whether it will be ERM or macular hole. And I think we all take for granted to remove the IOM and thinking not much of it. But with those publications, I think we should start looking at the IOM peel itself is not totally benign or atraumatic. I just want to comment on Dr. Setti's video. I think, number one, thank you for sharing that video, because not every one of us will like to share the surgical mishap. It takes a strong person to show their so-called mistakes. But those mistakes we often make one way or another during surgery, because I always said, if you don't want complication, don't operate. The minute you operate, you're going to get complication. You have to have a big heart to show your error with everybody. So number one, thank you for sharing that video so that we can all learn how to manage cases better. I found that perhaps if a second stain, after you peel the IOM, if you stain it again, they often highlight the ILM better. And that will allow you to pinch and grab at more easier, so because you can visualize better. And I think that could have helped. I don't think you were just being casual or careless, because the area you pinch were not that well stained, and you may have pinched deeper because you didn't have that much visualizations of that area, like identify the IOM distinguishing from the rest. So that could have helped you. And I think you have also identified a couple of very good learning points. One is that if you pinched and if you create a trauma or a small tear on the retinal surface, they don't need to be laser or treated, because they will heal nicely, and your postoperative OCT confirmed that. And lastly, you also showed the point that don't mess their clot, because the clot are there for a purpose to stop the bleeding. And if you remove the clot, it will bleed, and the blood will go away. We know that, and there might be a little bit of blood that mix into the vitreous post-op, but that will go away, and the blood that's on the retinal surface will also go away. They don't cause PVR, they don't cause any secondary complications. It bothers us as a surgeon, but it doesn't bother the patients, and it doesn't bother the outcome. So I think it would be a great lesson for the trainee to take from this learning video is that the clot you can trim it down, but don't remove it. I think that taking it away is problematic. Last point is that this is probably a small arterial bleed, and that's why it will bleed again. If it's a venous bleed, then you wouldn't have rebleed because the vein that bleed will be thrombosed much easier. But if it's arterial bleed, then the minute you take off the clot, it will bleed again. So that gives you some sense of the nature of the trauma. So that's all. But thank you for sharing it.
All of us
Can I
have
add a
this.
point?
All of us have this. The problem is that I'm using the double foot pedal. In my constellation, I've got always in the board 2 pressures. One is 45 to 50, and the other is the normal 20-25. Whenever we start just bleeding, we do it in epiretinal, I'm just pushing the foot pedal to the right side, and it goes to 60. And immediately you stop the excess fluid that is going to disrupt your visual field. This is the most important for me. I want to have a clear vision. And I fully agree with you. You should not remove it completely, or you should not retouch it again. So this video, from this point of view, was extremely good. But remember to raise the pressure very quickly, immediately, in order to have a little clock. And these are usually collateral vessels, that everyone who's peeling will have collateral vessel bleeding. I don't know anybody who did macular surgery without collateral vessel bleeding.
Sir, just a point. Wonderful video, Vaibhav. So I do 2 things in all my macular surgeries. One, I always stay in ILM under air for 2 minutes with the brilliant blue dye. I do a fluid air exchange, put a brilliant blue dye, and it gives excellent staining. In one of my upcoming videos, I'll show that. So, and I stain and peel under very high magnification and high resolution. Usually use a contact lens. So this gives me a great visualization and helps me to peel on areas where there are blood vessels. So that helps to avoid any bleeding. And otherwise, wonderful video. It takes a lot of heart to show your mishaps. So, great.
Thank you again, Dr. Sethi. Cool case. And I would like to invite now Saad. Hi, Saad. How's it going?
Good. It's all great. Thank you for great presentations.
Yeah.
Should I share my screen?
And I loved all comments from everybody, from Dr. Lam, Athanasios. This is how we learn, because as Dr. Lam said, everybody could have some pitfalls on those surgeries, but we gotta do the best as we can, and the case was actually very good. Thank you very much, Saad, for coming, and Vaibhav for giving such a great lecture.
Sure. So can you see my screen? Is it clear?
Sure.
Okay, so I'm just gonna go on what Dr. Sethi started. This is another, I call unfortunate patient. She's a 50-year-old lady who comes to see me with flashes and floaters in her right eye. She had a past history of a detachment, which I did for her 10 years before. On examination, her vision is 20/30, 20/25, and she had an acute PPD with some vitreous bleed in that right eye. Her left eye looks fine and retina is stable. Now, at that time, I asked her to wait. She came back with a dense hemorrhage. Scan did not show a retinal detachment. And then we waited and she came back with a retinal detachment. So we decided we're going to go for surgery. At this stage, it was just a straightforward vitrectomy. And you can see the old vitreous hemorrhage, superior macula, the nasal horseshoe tear. And at that time, this looked like a straightforward surgery. please notice that her fovea looks fine at this stage. So the surgery was uneventful. We did the laser, fluid exchange. I lasered the area of concern, and I looked at the periphery, and there was nothing. And then we ended up with S6 gas. She's done well postoperatively. The vision started to improve. The retina is flat. But then on the 5th week, she came back to see me with a discolored vision, and she developed a full thickness macular hole with a 2200 vision and a 600 size macular hole. I have not seen a lot of these, so I wanted to share this. Took her for another vitrectomy and a fovea sparing ILM removal, which again went very, very smooth. And I totally agree with the concept of restaining, if you're not comfortable or if you're not seeing very well. And I tend to do this fovea sparing from both sides. I don't go all the way to the arcade. I try to save some ILM just in case I have to come back. And again, this lady's done well. I tend to do an OCT within a week, and she looked fine, and she was doing very well. I left air bubble at this stage, but then she came back on the 2nd week with an endophthalmitis. So really very unfortunate patient. She's done 2 vitrectomies, so we just injected her with antibiotics. And this is how she looks 3 months. Her endophthalmitis, the eye is very quiet. The vision is 2100, but with a larger, unfortunate macular hole. So my question is, what would you do for a patient like this? And how frequently have you guys seen a post-vitrectomy RD macular hole? Thank you.
You should send her to your enemy doctor.
Yeah, I tried to, trust me, but she wants to stay with me because I did her other night.
If you don't like somebody, you say, this is the best doctor for this, you should go there. It's hopeless, it's fate. We, the Mediterranean people, believe in fate.
Yes, I agree.
Some people are like, they take the lighting. But it's full of unfortunateness. And I'm sure you did a fine job. The surgery looks perfect. Nothing you can avoid. But sometimes life is what is happening when we make plans to fix things. That's why surgeries. So
my question is, what do you think the underlying mechanism for the macular hole that develops after, vitrectomy for these cases?
Faith. I don't know.
Okay.
I don't know.
Can I? Wonderful presentation, sir. Unfortunately, last year I had a couple of cases very similar to this. Post-vitrectomy, uneventful surgery. Of course, I was lucky not to have endophthalmitis, but still had a macular hole. So I went into the literature and saw in these cases. So one thing which people have described is sometimes because of excessive laser, there is a certain like if you have used cautery or laser excessively, it can induce some amount of retinal contracture, which can cause the tangential traction can cause some macular hole. And these macular holes are very difficult to treat because once they've already removed the ILM, so we can only maybe anatomically close with free flap or some amount, some other tissue stuffing into the macular hole. But I don't think we can really have any great visual outcome. But having said that, these cases are very unfortunate, as Dr. Rathanas said that it is very difficult to manage. Otherwise, this internal retinal contracture due to post-vitrectomy cases is quite uncommon, but it happens.
Zad, that was a very interesting case and very, I think, very unfortunate patients. in terms of, you mentioned it's bad luck that with the patients. And I see nothing wrong with the original surgery. And some people reported the incident or the occurrence of macular post-retractome, attributed that to maybe cystoid macular edema post-op. And in cases of cystoid macular edema that are not managed initially, and they can rupture and cause macular hole. And the reason why we may miss that is that during the initial 2 weeks of the postoperative period, there's gas bubble in the eye. You couldn't see to the back of the eye, and you missed that and that opportunity to manage it. And I think in one of the previous meeting here, I think David Chow has shown a case of a small macular hole associated with post-surgery, and he treated it with steroids, and as the macular edema resolved, as the hole also resolved. So I think it's worthwhile give that a try for the post-vitrectomy macular hole. As you saw,
you mean intravitreal steroid or Ozurdex?
Either intravitreal steroid or even just topical steroid, and are more aggressive than your usual postoperative regimen, and see if you can settle the edema, because usually those macular holes are small. This is different than the one that you show in after the endophthalmitis. I think the first hole that you showed is relatively small, and if you treat it aggressively with steroid and see if it responds. If it responds, that will support that theory of the cystoid macular edema being the mechanisms. Alternatively, you can also do a Forcing angiogram to see if you see leakage in the fovea, and you know that macular hole, those perifoveal cystic changes, does not leak on fluorescein. So that will give you an idea if that hole will improve with medical treatment, and then you may not need to go in to do another vitrectomy. So that's something to think about. And but I think now it's tough. The hole is big, and lightning can strike twice, and for her, hopefully it won't strike the third time. So.
So I'm seriously thinking to send her somewhere else as a
It's not a bad thing to send it away.
Thank you.
My pleasure.
Thank you. Thank you, Saad.
Don't send it to Hong Kong.
Yeah.
Okay, I'll do that.
Yeah, I want to visit Hong Kong as well one day, you know, after these pandemics and now the war subject, so we gotta have things settled down. And but I want to visit you, all you guys, and also Greece, Athanasius, for your vitreoretinal summer meeting. That's going to be awesome. Would like to say anything about this meeting, Athanasius?
Well, I'm going to show you in my presentation. I will give you a presentation, a small presentation.
Sure. And now, because you are the next one to speak, I have here the video of Giant Tear. Can I share the screen for you?
I would, if you let me,
or if you
I
want,
would like to show you the whole PowerPoint together with the video in order to understand what I'm saying.
Okay.
Can I?
Sure, of course.
Then I share screen first. And then to find out the presentation. Okay. This is where I work.
We still cannot see your screen. Did you share it, Guilherme?
Yes, I did.
Athanasius is co-host, okay?
Let me try again.
We still cannot see the screen as of yet.
I'm thrown out of the meeting. I don't know. I have no visual contact with the meeting now. I have to go back again.
Okay,
Not
sure.
a minute. In a minute. And I have my speed is doubled. Don't know what's going on. Yeah. Meeting registration Zoom. Zoom meeting progress. No. You know what happened? I'm thrown out of the meeting. I have my voice.
Yeah, we still cannot see your screen shared, and
Launch meeting. I have to stop.
I have the PowerPoint over here. If you want, I can.
Okay, but I don't see anything. I have to
Okay.
go back to the meeting again. They launched the meeting. I don't know how it's happening.
No problem at all. And let me just, I'm opening the your PowerPoint. Actually, I have the keynote, but I'm opening
I
the.
cannot see you.
Sure. Let me.
I'm not connected only by.
Can you see the sharing?
No. I'm not.
Not yet. Can everybody see the?
Now I'm back. I can use yes.
Can you see now?
Okay. Yes, I can see.
Sure. You just tell me. I will pass the slides on.
Okay. Just hold on a minute. I need to share screen and the other screen sharing. Do you want to continue?
But if you are.
Hold on a minute. I need that minute because I have this problem that I changed. Okay. Now, can you see it now?
No, I see because I'm sharing actually the screen over here. But I will stop sharing, and if you want to try to share.
You stop sharing, and I'm going to do.
If you want to retry sharing your screen.
Okay. Can you see me now?
No, not yet.
But I'm sharing the screen over here. What's going on?
But I still can share for you, not a problem.
Okay, because I changed a little bit the PowerPoint. And this PowerPoint you have, it's
so I'll share it for you.
Okay. Yeah, I'm very bad with this kind of thing.
Yeah, can you see now?
Yes, I can. Okay.
Yeah, it is there.
The idea of presenting this next slide is giantess are particularly difficult. Can I have my voice not being doubled? My voice is twice. I hear my voice twice. Not only echo, but doubling them.
Okay.
I don't know how you listen to me. Hello?
Okay now? That's okay now?
Cannot hear you at all. I lost.
There is no echo now.
Now it's okay.
Now it's
Now,
okay.
The most important person about giant tears in Europe used to be G.D. Scott from Cambridge, the late Scott from Cambridge, who just evolved the whole situation about giant tears and silicon oil. Next. Next. Lost you again. Giant tears is a large, we have to remember that the most important for this is the differentiation between dialysis and giant tears. Giant tears is very difficult to treat because it's a large tear with a vitreous attached to the anterior flap. Dialysis is a large tear with a vitreous attached to the posterior flap. This is the whole thing, but the thing that somebody is seeing when he doesn't know, he just see a flap floating inside the eye and he thinks, next, he thinks it's the same giant tear. What is the main difference? The major difference is the treatment. The treatment of a true giant tear is very difficult because you need to clean everything to the periphery because everything is at the periphery of the eye. And most of the time you need to remove the lens because the axis of the traction is just behind the lens and you cannot do it without touching the lens. And it goes very fast to PVR stage because it gives a lot of pigment epithelium for the eye and to the large explosion, and it has radial extension. And there is slippage of PVR during air exchange. A giant dialysis can easily sit on a 3 millimeter sponge, even without vitrectomy. Next. So if it's giant tear or giant dialysis, dialysis can be just buckled without any vitrectomy, and giant tear needs to have one of the most difficult surgical procedures. Next. I'm using always true giant tears, I'm using always silicone oil. Silicone oil avoids hypotony and the migration of vessel dilatation from hypotony. And sometimes air is difficult to position in. Silicone oil, if you use it correctly, doesn't produce slippage. And so most of the time, next. Probably the reason, because we have 88 success rate with with giant tears without silicone oil. And that means that people is mixing giant tears and giant dialysis. And everyone seems normal until you get to know them, and everything makes easy until you find a true giant tear. Next. In this video, you can see a giant tear that I'm doing vitrectomy in the posterior flap, the flap that is folded, and nothing is moving, because all the real traction is at the anterior flap. You see at the anterior flap, all the traction is there. You can see even the 25 gauge trocar is involved to that. And you need to remove it. Sometimes people remove the whole anterior flap in order to be, if you don't do the removal at the anterior flap, then it's going to reopen again. And this is a very, very important issue to do. The next difficulty you have, when it's inverted, I'm injecting perfluorocarbon using the silicone oil, the syringe, the foot pedal. And while I'm injecting, the flap, if it's inverted, it's very difficult to remove, to go back. That's why I'm using a double flute system. With the other side, I have a flute needle that you can see here from the upper side that is just retracting fluid. So it makes a current. You can see here, it makes a current that is pulling the flap towards yourself while you're injecting perfluorocarbon. And then it seems easy because you've already fixed the major issues. The next. Next one, please. You can see, okay, can I go one slide back? You can see the flap here, the flute needle here, and the flute needle here. While this flute needle is sucking fluid like that, this is injecting with a foot pedal perfluorocarbon with just with the foot pedal, you inject it slowly, and it doesn't make any bubbles to make fish eggs. And this is a technique we're using to do silicone oil exchange and perfluorocarbon exchange without going to the air. Next one, please. We try to teach people. That's what we do with all the procedures. In Thessaloniki, 10 years ago, we decided to have a vitreoretinal summer school because summer is beautiful in Greece. Until now, we have more than 350 people from all over the world and from 26 countries. And training is treating cataract complication with primary vitrectomy and everything the next, and everything that people would like to see when they train. Well, the co-organizer of this idea was from Italy. It was Cesare Forlini, who I'm also mentioning him because he's the pillar of vitrectomy in Europe, and he died a couple of years ago, and I still remember him, and we'd like to have him back. But probably we'll meet him sooner than later. Next. This is the setup we have. We use technology, and people who have been there, we have full microscopes, we have bionic eyes, we have ingenuity system, because people listen about OCT, surgical OCT. People are listening to the new evolution, but how many people do they have this evolution in their own theater? So we just get the industry to bring us all the newest things, and people are coming there to learn tricks and tips from the most important surgeons that you have. Next. That's another picture of what it said. Next. This is the setup we have. We have this incredible bionic eyes that you have to remember, bionic with a K, if you want to do training for yourself. And we have the biome or the ABO system, and we have the ingenuity, and that's why you can easily see in the ingenuity, you can easily see, and we can remove the ILM, we can do vitrectomy, we can learn things of injecting silicone oil in these artificial eyes that you cannot do with pig eyes. Next. Next. And the next one is going to be between 4 and 8 of July this year. And probably we will have Hudson and Lam with us this time. And we have about 40 faculty people teaching 35 residents. So if we play, we win. So I would love to choose some of you for the next year or the next year. And Nataraja is planning to come, but he's always planning to do things, but he's always invited everywhere. And the last thing I wanted to say that in Europe, we are devastated from the war that is happening to our next door. I know that you don't like to talk about it, but the TV is always open, and we see refugees going out of Ukraine. And it's a horrible situation. Everybody feels depressed because we never thought that we have a war in Europe in 2022. Sorry for bringing that into the discussion, but I feel so bad that I have to share it with you. Thank you for having me.
Great honor, Athanasios. Great cases and great differentiation between your dialysis and the giant retinal tears. You showed us nice cases, and well, you said you like using silicone oil for mostly of the cases for avoiding slippage of retina. And how long did you keep the patient with the silicone oil? After it heals and the laser scars are okay, you just set them for removal?
There are 3 steps. One is, if you had a lot of PVR and a giant tear, and it's an unstable situation, that probably I will need to reoperate later on. Silicone oil buys you time. I mean, you can keep the patient like that, seeing something and working like that. And these cases, I wait a lot. I'm using only 5,700 silicone oil pressure of silicone oil, 5,700 only, which is purified, and it can stay much, much longer than you think it is. And especially in trauma cases or in cases with very horrible situations, one-eye patients always, we have patients that they have this for 5, 6, 7 years, because that's the only way. Whenever we try to remove the silicone oil, we have redetachments. So we try some people have silicone oil. But in normal cases, when they don't have a problem, we have a space of 6 months. But we are not so much fixed on the issue of removing the silicone oil, because we have a purified, very nice silicone oil that will stay much longer than you think it is. And only we remove it when it's better visual results for the patient. We don't have so much emulsification like in the old days when we use 1,000 centistokes and of industrial silicone oil. And I'm sorry to say that, but I learned silicone oil from John Scott in '83. We didn't have any of these tricks and tips for that. So silicone oil now is easy, but I don't like to change to Giantess from silicone oil to air gas fluid exchange, and then from air to go back to, from vitrectomy to air, and then from air to silicone oil. I'm from perfluorocarbon, I go directly to silicone oil exchange, perfluorocarbon silicone oil exchange, because this way I'm avoiding heavy slippage.
That's exactly the way I do. We like doing the indirect exchange with air fluid exchange, but I love that way. You know, you do directly and you see the whole thing and you keep an eye and avoiding this slippage. Very cool case. Does anybody else want to comment? I see. Oh, Pablo. Okay, Pablo.
I have a question.
Sure.
My usual approach in this case is to combine an encircling band with the vitrectomy. Do you think it can help avoid the retina slippage in these cases, to combine with an encircling band?
Lucas, we had a lot of discussion 10 years ago about this situation, because we are divided to people who put buckles and people who didn't put buckles. Now, sorry, I have something in my house happening. The thing is that when you put a buckle, you're shortening the retina. You make it less possible for the retina to keep the gap that you're leaving, and you leave much more space of choroid in the eye. So since we understood that, we never used again buckles for Giantess. And most of us that we discuss on this subject, we're going back to non-buckle surgery. It's not only not helping to close the slippage or something like that, it's just making the retina shorter than we should have. It's like having a double bed and you use just a seat of one bed. You have to stretch it, and it's not stretchable anymore if you put a buckle. You just push it backwards. And when you leave choroid, sometimes you have hypotony on that subject. But this is what happened after a lot of discussion. Some people are using still buckles and they feel comfortable. If you feel comfortable and you succeed with this, but I'm using always buckle for the dialysis cases. No vitrectomy, just a plain 360 buckle, nothing else.
Thanks.
Thanks, Pablo. If anybody want to comment, I see here João Teixeira. João Teixeira would like to make any comment on the case. Are we around? If not,
can I say something here?
Sure, Sad. Go ahead.
Hudson, do you hear me?
Φέρνεις το παντελόνι λίγο σε παρακαλώ από μέσα. Παντελόνι.
Saad, do you want to comment?
Retinosis, that's a great presentation. Now, my question is, how frequently now do you take the lens out? Because you mentioned taking the lens, and I agree with that. But do you still do that at this time, or you're doing cases without taking the lens? One point. The second point is, I totally agree on feeling sorry. Trust me, war will affect everywhere. The ramification is not only on Europe, I think it's the whole world is affected, and I hope peace will come back soon. And this is great work you're doing with the summer school. Thank you.
Well, if you can hear me, because I have a lot of trouble with the internet today, if you can hear me, the thing about the lens, whenever I tried to save the lens because it was a younger boy or something like that, and I would like to keep the lens, I felt sorry about it because in order to make a scleral pressure and remove the anterior part of the giant tear, the curvature of the lens doesn't let you to go there and you make touching. You're touching the lens, which is much worse instead of removing it and putting an IOL. So almost all my cases, when I have a true giant tear, I think if you really need to clear the base and to clear the area of the anterior flap, I think most of the cases I remove the lens, unless I have any contradiction to that. But sorry to say that, but almost always I remove the lens. Clear lens, doesn't have to be cataract.
Thank you, Athanasios. Great cases.
Can I add a
And
point?
Ashraya, want to comment again? Oh, Ashraya, do you want to comment?
Sir, Dr. Hudson, we presented a similar case in the Retinawesome Paris, and we discussed on giant retinal tears. So as our senior colleague said that we have moved away from buccal surgeries in giant retinal tears. They don't really help to do a to prevent slippage. So the main crucial step would be doing a silicone oil PFCL exchange. So that if you do it under chandelier, like we discussed in the previous Retinawesome, that can help to have better visual outcomes. So that is one point which I was trying to, what I'm trying to make is we can do a chandelier assisted silicone oil PFCL exchange to prevent slippage, which can give us better outcome.
All right, and I want to call now Dr. Professor S. Natarajan to join us. Hello, Natarajan. Good to see you.
Hello, good morning to all of you, and good evening to
Yeah, good morning.
Thanasis.
What time is it now in...
Nice new haircut.
So you are night already, no? It's, what time is in Mumbai?
Yes.
What is your time there?
It's 7 o'clock, 7 p.m.
Oh, 7 p.m. Okay, Natarajan. I guess you are already allowed to share your screen, if you will.
Yes, okay. I'll start. You can see my screen?
Yeah, pretty good.
Yeah, so this is I have two cases of trauma. Traumatic retinal detachment. First one is a road traffic accident. You can see the corneal sutures. And then you can see the retina totally detached. And from the temporal side, the retina is encapsulated to the nasal retina. And I'm using the chandelier elimination and using two forceps to open up the flap. And now PFCL is injected into between the hole, and then I'm using the retinal brush to flatten instead of the retinal massager, which will be by Dr. Jovanovic. And then I'm doing endolaser. There's some part of suprachoroidal hemorrhage is there, which I left it. And I'm doing a 360-degree laser photocoagulation. This is a patient who had an extensive choroidal hemorrhage following trauma. So actually, I'm this is 2 days post-operative after the wound repair done. So I'm actually increasing the intraocular pressure by injecting viscoelastic. I passed the 240 band all the 4 quadrants using the scleral tunnel. While doing the vitrectomy, I thought there was a bullous retinal detachment happening, and I thought it was a wrong placement of the infection line. But finally, it turned out to be a suprachoroidal hemorrhage, an expulsive hemorrhage happening. And I realized 2 minutes late, and then I used PFCL oil to stop the bleeding. But by the time it was late, so I controlled the intraocular pressure and injecting. And you can see the suprachoroidal hemorrhage, and I decided to stop at this stage. And then this is at the end of the first surgery. 18 days later, I went again. Okay, this is the end of the first surgery where I removed the buckle. And then this is 18 days later, the same eye. I'm doing a vitreous lavage. And you can see there is a subretinal heavy oil, which is there, the large tear in the temporal side. The PVD had not happened, so I removed the vitreous hemorrhage on the surface of retina. And you can see like a golden globule, that's the heavy oil, which is in the choroidal space. And I'm removing the last part of the oil. And using the retinal brush and clearing the choroidal surface. And now I'm doing a fluid air exchange. At that time I noticed there was a macular hole, hence I didn't use PSCL. I'm now using the retinal brush again to remove the clots which was on the surface of retina. And then using the cutter, I'm using mild suction and removing it. And also through the macular hole without touching the edge, I do a endodrainage and a fluid air exchange. And the retina is settling. And I also complete the vitreous-based excision. And there's a large break. I use the air silicone oil exchange. So that's the end of the 2 cases. So both the patient actually had a counting finger close to face post-operatively. The second patient had again recurrent PVR, so I had to operate again. But the reason I operate is that I think these patients, if you don't operate, they're not definitely going to have no vision. But if you operate, there's a possibility that in case the fellow eye gets some problem, I think it will it'll be like a stepney. That means it will be a supportive in case if the other eye has a trauma and the patient loses the eye.
Always easy cases. You choose your cases to be on the easy side. The difficult cases.
Yes.
You choose your cases to be easy cases. You choose comfortable cases, not to worry about. The thing that I like very much about your presentation and all this stuff is that you're fighting, that's Zivojnovic idea. You're fighting every eye. You don't say this is inoperable. You don't have this word in your vocabulary. And
Yes.
I would like to mention from my side, I'm doing also the same cases because I'm a student of Zivojnovic and I had some experiences that proved to be that way. First of all, if you have a horrible case on a 2-eye patient, they used to say, why you do the eye since you have the other eye okay, because this is hopeless. And first of all, how do you learn to do these cases? By doing. You don't learn by talking. So if you're doing a 2-eye patient, just getting ready for the 1-eye patient, because you get experience and you can do the 1-eye patient. These cases, in your specialty, is not for everybody. Not everybody has a trauma experience. Nobody is learning to treat trauma at school, at the hospital, or when he is alone, he has to do the trauma. First time, nobody tells me how to do it. So that's why we like the trauma school that we're doing in Uretina. The second issue is that I have cases where I did the worst eye, and this worst eye has 1/10 vision, 120, 150 vision. And then not many cases, 2 or 3. And the other eye got lost for other reasons, or for similar retina detachment again, PVR, lost. And they are depending on this eye. That's why in trauma cases, or in cases that you think hopeful, you have to try your best. Even if they keep the visual field, it's a different story. Having the visual field and not having the visual field. I fully agree with you. I'm a big fan of you trying these things. And we were a big fan of Cesare Forlini, who was doing also the same cases. And they say, why you do these hopeless cases? I don't know if everybody agrees with you. You have to fight every eye.
Yeah, yes, very well said. I agree with you, and maybe we have to find out from others what they say. I agree, and definitely I keep telling them, the young surgeons, I think you can definitely refer the patient to me so that you can tell the best surgeon has operated and still you don't have vision. And I think, and a lot of patients, when they lose the other eye, and this vision, whatever little, will help them to see their plate and eat, and also go to toilet, which I remember Raja telling that the patient will that time appreciate this side, which we thought, everybody thought, no.
All right. Thank you, Natarajan. These are really tough cases. And I want to ask you how often you still do a buccal. Because, of course, in those traumatic cases, if you have to go too much in the retina, doing retinotomies and things like that, sometimes there is no reason for retinotomies. But, of course, there are the good indications for that, and people nowadays, they don't perform as many retinotomies as they performed before. And so for those trauma cases, when you put the square buccal or the 240 band or 276 band or 42, if you press, if you tighten the band, how would you avoid these choroidals?
No, if there is a choroidal, no, I think this patient, it was a mistake, I think, that the fresh surgery, I put a buccal, and I think probably should avoid. And I think in a trauma case, I will reserve the buccal. I don't put in all cases, but in recurrent PVR, in case I know I'm not planning to do a retinectomy preoperatively, then I place the buccal. But if I plan, the retina has a very intrinsic contraction is there, there's the PVR and the surface of the retina and the subretinal space, then maybe we need to do retinectomy, and then again, I don't put buccal.
All right. Dr. Lam, would
Very
you like
nice
to
case, Dr.
comment?
Natarajan. It's watching. Good to see you.
Yes.
I just want to ask about the case. Did you use Danceron, like heavy silicone oil? The reason I ask is that the subretinal oil seems to be in the bottom. It's not floating.
Yes.
So
Yes.
One thing about Danceron or the heavy silicone oil, they are very pro-inflammatory. They tend to create more inflammation than just the silicone oil. And that might have been responsible for the increased PVR that create the tractions on the large brick and allow the heavy silicone oil to slip through the brick and went to the subretinal space. Yeah.
Yes. I think that was again probably I kept as a reserve, but I think I shouldn't have used the Danceron. I should have used the 1020 strokes. So yeah, I think it's a valid point. You're right.
Yeah. Nice case. I think I agree with what has been said, that we should try everything possible to salvage the eye, because a reattached retina will mean so much more to the patients in terms of navigations or even preservations of the group itself is important.
Yes.
I think it's wrong for a retina surgeon to recommend enucleation or eviscerations. In fact, I always tell my trainee that I never, ever eviscerate that eye. And I would do everything possible to save the eye. Yeah.
Exactly. Very good.
I don't know how. Sometimes when I have to do something, I give it to somebody else because I don't know how to eviscerate an eye. I never did one in my life.
Absolutely. It's not in a good retina surgeon's vocabulary.
Yes.
Natalie, are you coming to Greece also?
Yes, yes. It is in July, right?
Yeah.
Yes,
okay.
I already booked my tickets too.
Okay.
And I'm also going to South Africa on 5th March. And then on 12th...
It's not next door. South Africa and Greece is not next door.
No. I'm saying 5th March I'm going to South Africa for there are 4 trauma talks. And then after that I'm going to the whale vitrectomy meeting in Colorado.
Okay.
That's in March.
I hope everybody stays more than a week.
Yes.
Okay.
I'm planning to.
Okay.
I'm planning to stay for the whole meeting.
Okay, thank you.
And then, whenever I really, because every time I had some problem, this time I decided I already blocked my dates and I'm off to Greece and I got the tickets.
Now we have a war in Europe. I mean, I don't know what you, probably is like the old lady that she had endophthalmitis and the macula hole and everything. Whenever you try to come, something is happening.
Yes.
Okay. But we still love you.
Yes. No, I'm missing my travel. So I have to go to Brazil also to see Hudson. No? And I have to go to Wei Ching Lim also to go to Hong Kong.
Sure.
I'm missing all the fun.
Yeah.
We also do.
And because, thank you everybody. André Jucá is not ready yet, I guess. And I would like now to share my case in vitreoretinal surgery. Just a second. If you want to go first, Pablo. Pablo, are you ready?
Yes, I'm ready.
Okay, Pablo. If you want to share your case first, you go ahead.
Okay.
Pablo. Thanks for coming, Pablo.
Okay, thank you. Okay, can you see my screen?
Yes, pretty good.
And I'm having a lot of echo. Okay. Good morning, everyone. I'm very glad to be here with you this meeting. Thanks, Hudson, for the invitation. This is a case of a 61-year-old male patient with a history of 1 week of decreased visual acuity, of 20/60 at the time of examination, superior temporal retinal detachment with a tear associated with a lattice degeneration and vitreous hemorrhage. I perform a phacoemulsification with a foldable IOL implant without complications. Standard 3-port vitrectomy. Here you can see the break over the lattice degeneration. And when the vitreous hemorrhage was clear, I noticed an inferior break as well. Endo-drainage with perfluorocarbon, endophotocoagulation of the superior and inferior breaks, fluid exchange. And because of the inferior break, I decided to fill this eye with silicone oil. Everything went well until during the sclerotomy sutures, I noticed this silicone bubble coming to the anterior chamber. My first question to the panel is, how would you manage a case like this? At the end of the surgery, you notice silicone coming to the anterior chamber. What would be your approach?
It's a pseudophakic eye, Pablo?
Pseudophakic, yes.
Yeah. So usually I will use AC maintainer and then try to push the oil, which the same way it came, it can go. Otherwise, use the silicone oil extractor and make sure that the AC maintainer is on with a 20 pressure, and then remove the oil which is there in the AC, and make sure that the enough oil is there in the back and not extra oil, so that it doesn't keep coming.
Yeah, but this,
Yes?
yeah, I think you have to go back to the why the bubble cuts into the anterior chamber.
Yeah.
One of the most difficult things that you do with silicone oil is when you finish it, when you stop injecting. Usually, the eyes that the bubble is going to the anterior chamber is physics, and the physics say that it's overfilled. The eye is overfilled. Since you got air in the eye when you're injecting silicone oil, you inject silicone oil while looking at the pressure of the eye, and you have always the infusion on while injecting silicone oil in 20 millimeters of mercury. So infusion is giving gas into the eye while you're injecting silicone oil at the same time. This is why there is an equilibrium in the eye, and you cannot, and while you're dripping the silicone oil inside, gas goes upwards and the silicone oil goes at the back. At the end, there's a bubble of gas behind the lens, intraocular or real lens, and the silicone oil behind. Then you remove, I don't know what everybody's doing. I remove the infusion. I stop the infusion of giving any gas to the eye, and I inject pure silicone just to fill up the gap, because the eye becomes soft again, and then it becomes, and I check the pressure of the eye with my finger and see if it can. And I always leave a small bubble of gas behind the lens. This way I know that the gas, the bubble inside the eye is not pressurized to go to the anterior chamber. And the problem is that it goes to the anterior when the posterior chamber is overfilled. And this is very important to know. When it happens, if it happens, I go at the back of the eye, because if you try to remove the anterior bubble like people are doing with Hilon or Viscot, then as soon as you remove the Viscot or Hilon, more is going to come. This is the problem with silicone oil. If you wash it out, another bubble is going to come, because you don't reduce the pressure in the back of the eye. So I go at the back of the eye with my removal of silicone. I remove the silicone oil until the pressure, I remove silicone oil, like I'm removing silicone oil completely. I remove silicone oil, not completely, in order to have a less pressure in the anterior chamber. And then I remove the anterior chamber with a bubble by anything that I like, and then I re-inject silicone oil again. This is the end of the problem. Because if you try to remove it in any other way, it's like if you put Viscot, some people, you know what they do? They put Viscot in the eye, and then they use, and then they have a very high pressure next day, and they use dozolamide in order to have the pressure down. It's a problem every time you have silicone in the anterior chamber. For many, many other aspects, it's a problem, and you have to remove it. Sometimes, if I cannot remove it, I leave it there. I need to fix the retina. People think that silicone oil in the anterior chamber might produce corneal edema or whatever. Okay, it can do, but the first thing to save is the retina. Everything else can be changed or saved. But if you fix the retina, so at the end result, when I can try a lot of things and it doesn't work, I leave a small silicone oil bubble in the anterior chamber, I save the retina, and then I'm thinking when to remove it together with silicone oil. Sorry for being so passionate about it, but this problem, it occurs to everybody, and everybody's asking it. And everybody's not talking about it. So it's the first time I'm listening somebody really, truly say what you do now, why it happened, and what you do now. So I really get everything together. I had ready packed and send it back to you. Okay, I don't know the other idea. But
No,
this is my
the purpose of this presentation was to address what happens when you leave the silicone oil. I decided to put air in the anterior chamber, trying to push the silicone bubble down to the vitreous cavity, as you can see in the. And next day, IOP was 14. We can see the silicone oil bubble here and the air bubble. The patient was treated with prednisolone, moxifloxacin, and atropine drops. At 1 week, IOP was 16. 3 weeks after surgery, IOP was 12. The cornea was clear. 4 weeks after the surgery, and as Athanasius said, the main purpose of the surgery was to attach the retina, and I decided to observe the case. But at 6 weeks after surgery, patient came with pain. IOP was 46, flat anterior chamber, and I introduced acetazolamide every 6 hours. And what happened in this case, Athanasius?
Most probably, when you have this push of the bubble head, it's some redetachment. If the retina is redetached, because silicone is unelastic, everything is moved forward, and you change the pressure. Something is pushing everything ahead. And this is one thing. Did it have redetachment, or the retina was flat?
The retina was flat.
I think what happened is the oil has moved behind the pupil and create a secondary pupillary block, and that's what has happened. I was going to say when you try to push the oil out of the AC, it is not possible to push the oil back into the vitreous cavity because you have a posterior chamber intraocular implant. I would have proposed to push air into the AC, and before that you put a paracentesis, make a paracentesis, so that you have the oil push out of the eye, and through the paracentesis by filling up your AC with air at the end of the procedure. The advantage of using air is that you don't have the problem with the viscoelastic that give you increased intraocular pressure post-op. In your case, because you didn't create a paracentesis, the oil has nowhere to go but to stay inside. You do fill up the AC with air, but the oil also stay. But I would have done what you have done, to have waited, because the air bubble, the silicone oil bubble wasn't that big, and you couldn't have caused a problem. I think it's just unfortunate the oil managed to get behind the pupil and create a pupillary block.
Yes.
One thing people don't know a lot of is that the oil, when it cuts, when they make 2 bubbles instead of 1 oil, they cannot be reconnected again. They don't have sufficient surface tension to reconnect bubble that is cut off. And if you remove the air from the eye through the paracentesis, and if the eye becomes smaller, then again, it's going to come again up. So
yeah, no. You leave the air in. Yeah, you let. Don't try to take things out from the AC. The minute you try that, the oil come back.
Yeah, exactly.
Dr. Lam, I would like to.
I can see now the picture of what's happening.
Have a comment.
Okay,
Doctor.
The echo is back. Okay, this is the UBM. Silicone oil then remain at the vitreous cavity without complications until the 6th week with a small bubble in the anterior chamber. And after that, we can see at the UBM, silicone came to the anterior segment to block the pupil and push the iris forward. I did many inferior YAG laser hyredotomies, and the anterior chamber filled immediately, and at next day the IOP was 14 without a set of solamite. This is after the iridotomies. And the UBM after laser, showing the formed anterior chamber again. One week after laser, IOP was 15 with brimonidine, dorzolamide, and timolol drops. And 2 weeks after laser, IOP rise again to 36. We can see again the small silicone bubble. And I decided to take out the silicone oil less than 3 months after surgery with a 2-port approach. My initial plan was to leave the silicone oil for 6 months. I perform as the anterior chamber silicone oil extraction. And the release of any possible anterior synechia. With a forceps. And at the end of the procedure, I checked the retina. Everything seemed okay at the posterior pole and the periphery. After silicone oil removal, the IOP was 16 with no medication. And my question is, can we say that? We had a happy end after all that complications? Not really. The patient, after the silicone oil removal, complained of a central scotoma in this eye. And in a retinal examination, I found this. Perfluorocarbon bubble under the fovea. With a silicone oil filled eye, it was impossible to notice subfoveal bubble. And what was interesting to me is that I didn't notice this bubble during silicone oil extraction, as you can see again in the video, but perhaps the image was not very clear during the procedure. And the key points or take-home lessons to me from these cases are what Athanasius said: we have to be careful with silicone oil overfill, mainly with mechanical systems. I personally feel more comfortable with manual injection of silicone oil. The management of silicone oil migration to the anterior chamber is always challenging. The post-operative complications of silicone oil-filled eyes, like pupillary block glaucoma, and the migration of perfluorocarbon under the retina. Could it be because of the high IOP in a silicone-filled eye? And the management of perfluorocarbon under the fovea will be a topic of another presentation. Thank you very much. I will stop sharing my screen.
Have a comment, can I make it?
Yes.
Yeah, sir, that was a wonderful presentation. Just that what Dr. Lam and Dr. Athanasius mentioned, there are 3 options which whenever I get a silicone oil bubble in AC, there are 3 options for me. I use a vent. In Constellation, we get a vent which we can put in the other port other than the injecting port to see whether the pressure is being released when we are injecting the silicone oil, and also to see if the oil has come to the level of pars plana. So this helps into preventing overfill of the oil bubble. So once the oil bubble comes into the AC, as Dr. Lam said, it is very impossible to push it back. So what if it is a small bubble, I wait for 2 to 3 weeks and remove the silicone oil completely. Or if it is a larger bubble, then I remove the silicone oil on table completely and do the surgery again to make sure that there is no oil in the AC. Because all these sequelae can be avoided, because once there is corneal decompensation, becomes very difficult to manage later. So sometimes patients have landed up in DSEC and PKs in managing corneal decompensation. So I don't really wait for a longer time, because 80 to 90% of the retinal strength comes in 3 days, and by 3 weeks the corneal retinal adhesion happens with laser. We don't have to wait for a very long time to remove the oil. So these are the 3 options I generally do, and this is one situation I don't want to have the oil in AC. If it is there, I do any of these 2. Thank you.
Okay, Guilherme.
I think we all had this kind of situations. If I wouldn't to mention something, a question, how many centistokes of silicone oil are you using? What kind of silicone oil are you using?
1,000.
Well, this is my first comment I would like to make. I stopped using 1,000 5-6 years ago, and I had much less problems like that when I'm using 5,700. And something you cannot remove at the end. And the other issue is you have an eye with an IOL. This eye didn't have some broken posterior capsule, or it was because if there is a connection between the posterior capsule and the back of the eye, then you need to do an endo-iridectomy when you put the silicone oil at 6 o'clock. It's impossible if you have any communication between anterior and posterior and not to have a block. That's why we use always the endo, and the endo we're doing with the vitrectomy probe, not at the end of the operation, because if you do it at the end, you make suction and you might have from the endo some silicone oil. You do it before the silicone oil, the endo. So this is another tip I would like to give you, not to use endo-iridectomy at the end of silicone oil injection. Do it before injecting the silicone oil, and then you don't have a problem.
But
and
during the excuse me,
during the
surgery, yeah.
Sorry.
During the surgery, I didn't notice any communication, any capsular break. It was.
Well, you can understand when you have a blockage, that means that something was going past the capsule to go. So if in order to have past the capsule, there might be some problem there. And the other thing, people that when you try to do YAG laser in a silicone oil filled eye, it's not the same like other eyes. First of all, when you do YAG laser, the plasma is going to make bubbles. So every shot you make multiple bubbles. I don't know if you have this problem. And then the second shot you make is closing the hole. It's not going to be a stable hole. It's very difficult to make a correct YAG laser under silicone oil. I don't know if you have the same problem. So it didn't happen to me. It did happen to me. All of these things that you said happened to me. But I'm trying to avoid them by using these tricks and tips. I'm doing that. But it's impossible. Silicone oil has a problem. First of all, it's very good if you use it in the wrong eyes. If you use it in eyes that they don't need silicone oil, then you get only the trouble. You don't need the benefits of it. If you use it correctly in the eyes that they cannot be done without silicone oil, then you think I did my best for an eye that I can save. And I'm sure you said it in the first year before, because we have an inferior hole, I use silicone oil. It would be much easier in a flexible eye. I'm not judging anything. I'm just discussing that. For the 6 o'clock to put a small buckle instead of silicone oil. And silicone oil has a lot of trouble including if you use it. So people don't know that, and you think it's a getaway machine. And I think if I want to sum up everything, I love the 5,700 or 5,000 centistokes. Everybody's using that. I'm using machine injecting, and I'm not in so much trouble as before if I select correctly the eye. On the other hand, I have to congratulate you because you did every step correctly. Every step. You face the problem in the correct way. And I'd love to have your video to teach. And I'd like to ask you if we can connect in the school together, Victor, and to do just a discussion in the school with people on how to face the situation, because your video was fantastic and the whole presentation was one of the best I've heard for so many years that I'm doing the same job. And thank you for showing us.
Thank you very much. And one last question. What do you think is the cause to the subfoveal perfluorocarbon? Is because the high pressure in a silicone oil filled eye?
No, subfoveal perfluorocarbon was because the perfluorocarbon was filled a little bit higher than it should be, because the perfluorocarbon goes in from higher pressure to lower pressure. This is physics again. It's not something you do. So if you have perfluorocarbon near the tear, inferiorly or posteriorly, and for a minute with the transfer of pressures, the pressure at the hole was higher than the pressure on the perfluorocarbon, then a little bit of perfluorocarbon will go through the tear. So the perfluorocarbon went through the tear. There's no other way to go there. And it went not from the back of the eye, the 6 o'clock tear, it went from the top tears that you're shaving. And I saw something else you're doing beautifully. You do scleral depression shaving. When you do scleral depression, the whole pressure of the eye is changing every time you scleral depression doing it. So when you leave the eye with scleral depression, there is a chance for perfluorocarbon to jump in the tear that you have already opened. So this is the mechanism that happened to me. That's what I'm telling you, not only, but it's absolutely physics. The fluidics of the vitrectomy is something people don't teach. And that's why we have another thing that we'd like to tell you about CVRS, and people would try to attend to that. We have Michael Cardamone, which everybody, if you know Michael Cardamone, is the guy who made the constellations, the guy who made the 3D, is the guy who is the top mechanic on this subject in the whole world. He's going to give us a talk about 1 hour about vitrectomy fluidics while you're doing it, how much they change. I'm sure that in Hong Kong, you know him.
Yes, I just want to add, I agree completely everything you said. I want to add another aspect for the reason why you have the subretinal perfluorocarbon fluid is that with this small gauged vitrectomy, we have higher float, and that's why you have turbulence, more turbulence. In the old days, when we use 20 gauge, we don't see as often the subretinal perfluorocarbon as Dr. Antasis said, that during the exchange, the perfluorocarbon bubbles find a way through the superior bricks, the larger bricks, to get in and then get trapped. I remember when I first, when we were using the 20 gauge, I never seen any subretinal perfluorocarbon bubbles. But once we move the smaller gauge one, we start seeing more and more of that reported.
Do you want, absolutely correct. Again, you made the best discussion. Do you know, to see how strong is the fluidics of a small gauge, everybody from you have removed silicone oil. And while removing the silicone oil, you have an infusion inside the eye that is 25, 30, whatever you have. At the end of the removal of silicone oil, have you seen the current of the fluid from an infusion hitting the retina? It's incredible. It's
Yes,
just like making a hole.
Yeah. So
that shows you that the physics again, the fluidics, the smaller the lumen, the fastest the entry and the bigger the force that is hitting the retina. So in cases like that, I'm fully aware of that, and I forgot to mention it, the bubble that you make, and injecting perfluorocarbon on silicone oil manually, it's very difficult to control normal turbulence injecting PCL. So that makes the soap, that makes the fissile, the eggs, and it blurs a little bit the area, and you don't see that some bubbles can get in. So I would much prefer to spend a little bit more and inject them with what's the name of that you said, the injector?
Yeah, the viscous fluid injector.
Viscous fluid injection system, because it goes very slowly and it doesn't make any bubbles. These are tips that we got it the hard way, not the easy way. And again, I would like this video. It's something I never said everything so clearly, and you saw, Victor.
Very nice discussions. I want to point out that I solved, as you commented, Athanasius, that you are using for so long this 5,000 centi-Stokes silicone oil. I love using the 1,000. And of course, if I need to use the 5,000, I use it too. But I don't have these problems. It's rare to have this subretinal PFC under the retina, because I like, as you said, you keep looking, and if you have this tear in the periphery or have a break, you go with the silicone oil exchange directly from the perfluorocarbon liquid. You go straight up, and you remove the perfluorocarbon liquid until you get the edges of the break or tear or whatever, so you don't miss any perfluorocarbon liquid, and it actually does not go inside and underneath the subretinal space, so it's unlikely to get this subretinal bubble. This is one thing that I like doing. And of course, if the case doesn't require too much perfluorocarbon at the periphery, like if I'm going to present you a case here of diabetic retinopathy and I use perfluorocarbon liquid, and I don't want to use perfluorocarbon liquid up to the edges, because you actually need to be concentrated more on the macula. And I like doing the direct exchange, and sometimes, and it's very common, when you go indirect and you remove the perfluorocarbon liquid after an fluid exchange, especially in small pupils, and especially when the media is hazy, it's very common that you get these silicone, these perfluorocarbon particles that you missed somewhere because of the view from the fluid exchange maybe halts you from having a very good view from the tiny, small little bubbles. So I like doing that, and I usually don't get this subretinal silicone, subretinal perfluorocarbon liquid. I want to ask Dr. Lam, you commented by avoiding the silicone oil at the anterior chamber that you do this paracentesis. But usually the paracentesis are very self-sealing and very small. how could that avoid silicone oil from coming towards the anterior chamber?
So what I was saying in the case that we were discussing is that when you have a silicone oil bubble in the anterior chamber, and if you want to get rid of it, because a small silicone bubble in the anterior chamber, you don't need to. And remember what was said already. I think that Nick was saying this. Under air, oil sink, air floats. So if you pushed air into the anterior chamber and you create a paracentesis to allow the oil to escape, you fill the anterior chamber with air, and whatever oil in the AC get pushed out from the AC, the oil from the back won't come to the front, because as long as you pressurize the anterior chamber, and as you said, the paracentesis is self-sealed. So the air bubble in the AC will maintain the anterior chamber depth and pressure. That will prevent the oil from coming forward. In fact, you should keep the patient supine for the first part of the day, so that the oil still stay in the back, because by gravity, oil under air will sink.
Yeah,
so you wouldn't try to work.
This is
you
Dr.
said the
Lam.
magic word.
Dr. Lam, that I remember from...
You said the magic word. You know what's the magic word? When you want to remove something with silicone oil from the anterior chamber, you have to pressurize the anterior chamber so much, because if you lose the pressure in the anterior chamber, more silicone oil is coming up.
Yes.
So this is the trick. If you put gas continuously that is overfilling the anterior chamber, no silicone oil is coming, and then you close the gap. But you should not just put a bubble of air and then remove because this is going to be hypotonic, and then more silicone oil is coming up. So the magic word is anterior chamber pressurization in order to remove the silicone oil from the anterior chamber. Thank you for showing that so clearly.
Yeah, I agree that. And Dr. Lam, I remember it's a teaching from you at the University of Toronto. I remember when I have this air in the anterior chamber, of course, if you have the patient position face down very soon after the procedure, the silicone oil might occupy the space in the anterior chamber. So that's why, as Athanasio said, and we got to keep the pressure up there. But of course, how long would you leave the patient in the facing up before having him facing down for a procedure like retinal detachment? You have the anterior chamber filled with air, a complete fill, like 80% plus. And how long you keep him there with this air before asking him to face down? Because if you ask him, oftentimes happens, to face down exactly after the surgery, and then the silicone oil could fill, especially if it's 1,000, the anterior chamber.
The air in the AC will go away in a day, or at least go away very much in a day. So the next day, you see them for follow-up, you see maybe a 10% air bubble or 20% air bubble in the AC, and you'll be fine to face them down after that. The air in the AC goes away fast, because the exchange allow it to go fast.
All right. I just want to comment that I like removing the subretinal PFC with the MAD1, cannulas. They are very tiny, and as we commented in previous cases as well today, I have the possibility of using the Constellation system, the aspiration, but I like doing that manually. And if you get control in your hands, you don't need to be too forceful, you know. You just pull a bit, and then the perfluorocarbon just leaves the bubble and it collapses. I have some videos on that. And I prefer that. And of course, if you have the automatic system and it just keeps stepping there very slowly. I was talking to and discussing this issue with Pablo Cibilis like 2 weeks ago. And if you have any other ideas. And so, thank you, Pablo. This is a great case. And congratulations. This is a great images. I would like to call Ashraya Nayaka. Nayaka is almost like a Nakamura, no? Ashraya, a great pleasure to have you again. You started your presentations in Retinawesome Paris, as you mentioned. Thank you very much. Retinawesome Paris will be presential this year again at November. So if you want to share your screen and present your case, go ahead, please.
Thank you, sir. Thank you for those kind words and the opportunity. Thank you so much. Are my slides visible, sir? Hello? Are my slides visible?
Yes.
Yeah. So today I'll be talking on management of persistent submacular fluid post successful pars plana vitrectomy for diabetic combined RD. Of course, I don't have any financial disclosures. Please let me know if the audio of this video is audible or is it audible, sir?
Yes.
Yeah. Okay. Now.
This is a 55-year-old male diabetic patient, vision of 20 by 200 in the left eye with macula involving tractional retinal detachment. He underwent 25 gauge pars plana vitrectomy. After anterior vitrectomy, truncation was done and all tractional bands were removed. Brilliant blue dye was used to stain the island.
Ashraya, if you want to comment, because your sound is a little low, if you want to keep commenting, if you want to move back a little bit your video, just go back, and if you want to comment, I think the sound is going to be better,
yeah.
you know.
Yeah, sure. Is it better?
This is a 55-year-old male diabetic patient, vision of
Yeah, it is still slow. You know, I mean low sound. So
yeah. So
maybe, if you wanna mute it and then you comment, I think it's gonna flow better.
Yeah. So sure. So this is a case of combined diabetic retinal detachment. Patient was lost to follow-up for almost a year. So he came, and that is when we took up for surgery. So this was uneventful surgery. The macula was detached. I used the pinch and release technique and removed the ILM. Since there was a lot of subretinal fluid, I drained it in the first sitting itself and lasered it as well. So, and I used a silicone oil tamponade. And post-operatively, even after 2 weeks, rest of the retina was attached. The central retina was still detached. On OCT, I could see this hyperreflective echoes, which showed that this fluid had proteinaceous component, and that was making it hard to reabsorb. So I waited for 2 months after the vitrectomy, but things didn't change. So then I removed the silicone oil, did extended ILM peeling, wide ILM peeling beyond the arcades, And again, since I thought there is a proteinaceous fluid, I did a subretinal lavage as described by Reichenstein et al. So after that also, post the second surgery also, the fluid decreased a little bit, but it didn't persisted. So I thought it might be a CSR, and I did a FFA, but it didn't show any focal leak. So CSR was ruled out. And subsequently, then after around 6 months, I again took it up for surgery and tried to remove that subretinal fluid using PFCL. I did a fluid-fluid exchange and again a subretinal lavage and lasered it and put a gas at this point of time. Then rest of the retina was attached, only the central retina was detached with even after 6 months after the surgery. So then I waited for almost 14 months and because there was nothing much to be done, and retina was attached and vision improved to 636. So this was post wide ILM peeling and long observation. And as we know, persistent submacular fluid is seen in other cases also. Only observation is something which we keep doing in other cases. But in cases where there is chronic detachment, there can be decreased elasticity and shortening of the retina. In this, wide ILM peeling works. And Ahmed et al. Has already showed that if you observe it for a reasonable time after doing a successful vitrectomy, you will serially see this kind of resolution over time. It might take 14 to 16 weeks, but again, Jung et al. Told by doing a wide ILM peeling, you can increase the elasticity of the retina and can achieve a faster macular reattachment. And by doing it in primary sitting itself, you can avoid all these things. Once you have done a successful surgery with a wide ILM peeling, even in 1 or 2 cases, if you have a subretinal fluid, you can continue to observe. And with whatever the Jung et al., whatever 5 cases they have reported, it took a mean of 10 months plus or minus 4 months for the fluid to completely resolve. So this is the final outcome of after 14 months. So observation and wide ILM peeling is the way to go if you have any residual subretinal fluid. Thank you.
Great to see. Some echo?
Very well presented, but just one question. How you managed to have such a beautiful OCT under silicone oil at the first time you did silicone oil, finding out that under silicone you have so much subretinal fluid? It's beautiful. What kind of machine you have?
You have to unmute. Asharaya.
Sorry, sir. So we have 2 OCT machines. One is a wide field OCT machine from Avanti OptoView and another from Optopol Revo FC. Both have very high resolution, almost has one has 40,000 scans per second and the other one has around 60,000 scans per second. So they give very high resolution.
Yeah, good. Thank you. Very nice way of talking about the same subject. We all will believe in that. So many people do a little bit of laser at the end just to increase, but it's chronicity that is making the problem. And that's what you have to point out. That in chronicity, we cannot do anything about it. And congratulations on the presentation. We take some keywords were very nice. Thank you.
Thanks.
Can you listen now? Just a second. Okay. In order to avoid the echoes, I'm self-controlling my mic here because with the technician, but things are getting better now. I may do the comment. Ashuraya, great case, and these issues of subretinal fluid and perfluorocarbon subretinally, this is amazing. And of course, it's very interesting to have wide-angle vitrectomy viewing systems. Otherwise, we could miss fluids, we could miss perfluorocarbon liquids, and anything else that could go under. And also, even air could go under the retina, and we could get this subretinal air as well. Do you always use the wide-angle vitrectomy viewing systems?
So we use this Carl Zeiss biome. So it gives a very good visualization of the periphery.
All right, because next case I'm going to discuss, and it's also a diabetic retinopathy patient. And you know, the issues on peeling the ILM, yes or no, and especially when you see, when you had this, like I'm going to present my case, but I'm just comparing to yours as you have these diabetic retinopathy patients. And also if we could compare these patients with retinal detachments without diabetic retinopathy, and how often you guys think that could be good, not only to attach the retina, but to avoid proliferative vitreoretinopathy, PVR, to do the ion peel in macula of retinal detachments?
Sir, recently there is a paper, I forgot, I can share it on the chat. So the ILM peeling is not always necessary in detached retina, unless you are forced to do an ILM peeling, like you have an associated macular hole, or there is a macular pucker where you have to relax the retina for it to get attached. Unless it is so required, there is no need to do an ILM, because you might cause iatrogenic damage. Then you'll have to use, I generally hate using any PFCL in any of my cases. So I generally stain it under the air and do ILM peeling. But having said that, there is no need to do ILM peeling in all cases. Only if there is an associated macular hole, ERM, or pucker which is needed, then you have to do. Otherwise, you can just do the basic steps and close it. If the need arises, we can always do it subsequently once the retina is attached. Okay,
do you have a different idea on that, Dr. Lam? To peel or not to peel ILM? I usually do that in diabetic retinopathy patients, in the case I'm going to show, in the case I saw from Ashuraya. But how often you do that, and any different thoughts? Dr. Lam, any different thoughts on...
Sorry, can you...
Oh yeah, any different thoughts on ILM peeling in diabetic retinopathy patients, and or you know, patients with MAC of retinal detachments? Do you have any idea? Do you think that doing the ILM peel for plain retinal detachments without PVR would help anyhow?
I personally doesn't do that, and the reason, as we have discussed earlier on, that ILM peeling has the potential risk of causing dehiscence of the nerve fiber layer, and I don't think it is a benign procedure, and I'm not convinced that peeling the ILM will reduce the PVR. I think that a more meticulous vitreous removal will help, and potentially the use of intravitreal methotrexate may proven to be more effective than doing ILM peeling, I would say.
Yeah, I agree with you. But especially in these diabetic retinopathy patients, like for example, the patient has this huge vitreous hemorrhage and very dense, and then you cannot actually see.
You have to unmute yourself.
Oh yeah, just put the, like, for example, patient with diabetic retinopathy, and you cannot see the fundus because of a dense vitreous hemorrhage. And after you've done with the vitreous hemorrhage, the vitrectomy, and then you see there, as Ashraya pointed out, macular folds and some epiretinal tissue. Even if you did not have this OCT before, at this time, whenever I see folds, macular folds, whatever epiretinal tissue, and so I decide to go for the ILM peeling in those diabetic retinopathy cases.
I probably would peel the epiretinal membrane and the preretinal fibrosis, as you mentioned. But personally, I don't go beyond that. I don't go after the IOM. I think, as you mentioned, the reason why you go in is because of diabetic retinopathy. It wasn't much of the ERM. And if you find ERM there or preretinal fibrosis, I think it's reasonable to peel them. But to go after the ILM, I think it just potentially added the risk of additional surgical time and the risk of complications. I would consider try to limit that.
I agree with you. We gotta be extra careful, and of course, I wouldn't do that in all cases. But if you didn't do it after a while, you can still do angio, OCTs, and see whether the patient has the potential for getting the vision better with the peeling, the next surgery. Thank you. And I want to share my case, and just a second. Let me see. I don't know if you see my screen.
Yes, we see your screen.
Just a second here. Okay. So this is a diabetic retinopathy patient, as I mentioned. Yeah, this is the Eye Bank Foundation. That picture before was the. This video is not playing well. I'm gonna get a smaller version. Just a second. We need always to have the plan B, So these videos are now it's flowing better. Can you see the video? Can you watch it?
Yes, sir. Yes, sir.
Yeah. See, this is a vitrectomy for severe diabetic tractional retinal detachment with brilliant blue assisted ILM peel under PFC. You see, you have this diabetic fibrotic patient in fibrosis at the macula, and the pupil did not dilate well. But as you see here, you have too much traction, sparing just the very foveal, and you have the traction in the superior arcade, nasally with hemorrhages, and inferiorly as well, exudates, edema. And the patient is phakic, so you got to be very extra careful here to reach the peripheral vitreous without hitting the lens. And using the cautery, because now I'm nasal and too much hemorrhage over there, of course, I cannot be just pulling on that area, otherwise I will detach the retina even more. So my approach here to keep the patient phakic and not to go too peripheral, and is to keep the lens safe, and also do the vitrectomy without pulling much to avoid subretinal fluid from getting into the macular area. Now I'm performing the air fluid exchange, as you see here. I do 100% exchange, and to keep space for the brilliant blue. As you see here, I just leave the brilliant blue for 1 minute, not more, just to stain the whatever ILM or epiretinal tissues that come. And I'm removing this fibrotic, this epiretinal fibrovascular tissue around the optic nerve. And now that the macula is free, I'm putting perfluorocarbon liquid over the macula, and I have this great view from the macular lens. And now I start the ILM peel. And it's interesting, I love doing ILM peel with the perfluorocarbon liquid, because the perfluorocarbon liquid does not let you out of control of the peeling action. And if you grab the edge, you have much more control over the peel, and you can go over, and extend it more and more, and 360 degrees. And it's interesting now, I'm going towards the periphery, the very periphery, to do a relaxing retinotomy, because if I just leave the retina detached there at the nasal side, superior, inferior, and I do nothing, and then the retina could detach. I'm doing now this direct exchange of perfluorocarbon for silicone oil, and as you see, we get up to the last bubble of the perfluorocarbon liquid, and the retina gets attached. This is post-operative period. The patient is counting fingers, and good result, good retina look at the end of the case. So that's why I was commenting that I like doing this ILM peel for those cases, and that the result is so much better that I think that, of course, you gotta be very, as Dr. Lam said, if you pull too much and forcefully on the ILM, you could actually dislodge their fiber layer there and all of the rest. And you gotta be extra careful, of course. But if you have the PFC on the macula, the action of peeling is so much better, so much easier, and your control over it is much better. So this is my case. Thank you very much. And if you wanna comment. Atanasio, would you do anything different?
The thing is, I cannot do so much great ILM peeling on the perfluorocarbon. I'm not that good. Technically, I'm not that good. I'm trying to avoid ILM peeling because I don't want to mess up any other cases that I'm doing in the meantime. When there are difficult cases, I'm trying to avoid ILM peeling because I might do something worse than not doing it. But in your case, I think I'll follow your advice. From now on, I will try to do it on perfluorocarbon. But you dye it first. First you put the blue dye, and then you put the perfluorocarbon. That's the only way of doing it. And then how you wash it out first, and then you put the perfluorocarbon at the end. That's why it's so great.
You know what I usually do? I do the vitrectomy, exchange.
You don't.
And then after the exchange, I usually put the brilliant blue and let it go. And if you have a good staining of the ILM, it's okay, and you can remove it. If that does not happen, and I've seen many videos from Didier Ducournau from France, and he comments on that. If you have too much astrocyte proliferation, too much epiretinal tissue, of course, the ILM is not going to stain very well. And then after removing this first epiretinal tissue, and then I would put brilliant blue back again. I would do double staining with brilliant blue. And of course now, at the second time, because I already removed the epiretinal tissue and the epiretinal membrane, now it's not necessary to do another fluid exchange. So I put the brilliant blue straight towards the macula, on the macula, and so it stains very well.
Hudson, you don't use any membrane scraper like Finesse?
No, I don't use. I could use, but you know, when we had these scrapers at the beginning, I used them, but for a while only, I'm more comfortable with the forceps. I'm more comfortable, and I think it's easier to grab the membranes like that. I think this is a matter of technique, of what we're more comfortable doing. And what do you use for the island peel?
I use a membrane scraper first, and then the forceps, but I always use a scraper.
I always tell the fellows and the residents, especially the fellows, that they keep following us in the surgery and doing the surgeries. I always tell them, if you got a good view with a good macular lens from the fundus, from the macula, I have this great macular lens, and then I even zoom it in more. So you are so close to the macula that it's not difficult. Of course, it's very easy to get the membrane. It gets so easy because you have such a good view. Oftentimes, you gotta, if necessary, you gotta scrape the cornea to have a better visualization. But if you get a very good view, and if you are, you know, used to the forceps or the scraper, I think either one is gonna help. I think it's your preference.
I have a tip for the fellows that I'm using, and I'm using it myself sometimes. I'm using a flute needle with a soft tip at the end. Before I'm doing the dyeing, before I inject the brilliant blue, I just sweep the area around the macula. But you have to be very light on doing that. You just fondle it around it. And then when you eject the brilliant blue, it gives you sometimes the starting point. You have scraped it gently, and it gives you the starting point. Because I think the most difficult thing in pitch and grab and remove is the starting point. When you start, everything becomes easy. But before that, you can pitch. And usually when you say Didier used to tell me, you grab, you pull, and if everything comes together, you leave it. You grab, you pull, and if something doesn't come with it, then you open it. So this grab and catch technique, Didier's technique, which an absolutely brilliant surgeon, I can tell you, I've seen it doing surgery. And I think, Victor, the beginning is very difficult. And I'm doing this because I have this instrument. The finesse is fantastic, and I love it, but the finesse is costing a lot of money, just to put a plus finesse. So I already have the flute needles, and if you use any Tano scraper, even Tano, the late Tano didn't like to use Tano scraper because the hard scrapers are removing not only the ILM, they are just mobilizing the pigment epithelium underneath. And you have microperimetry problems afterwards when you move the pigment epithelium. So it's just removing the ILM, the preparation of removing the ILM, it's another technique. It doesn't have just one step. It has multiple steps, how to catch it, how to remove it, which way to pull it, how much you pull it. And the last issue that I want to mention is the smaller the tips that you're using to remove the ILM, the more bites you have to do. Because with 20 gauge, you make a bite, you put it, and everything comes together. With 25 gauge, you need to multiple, and with 27, because you have smaller mouth, you need to do it a lot of times. So there's something pro 20 gauge than against. Now they try to make forceps for ILM that they open up and they're flat and have a bigger lumen at the end. But I don't know how they do. But remember, soft caressing the retina with a flute needle can give you access.
Okay, Dr. Lam, what about your technique? Could you share it with us?
The technique for can you be more specific?
Yeah, your technique for
starting up ILM.
ILM peeling.
So I do use the pinch and peel technique, but if I don't get it, then I will use either the finesse or the diamond dusted membrane scraper that been mentioned by Tenno, and it's always difficult to start. But all you need to do is to get the first part going, and then the rest will come. I found that membrane blue or the dual blue stain reasonably well. I don't know people use ICG, and interestingly, I think ICG actually stiffens the membrane, the IOM, more, and when you use that, it makes the peeling a little easier. When I was in Toronto, we use ICG a lot. When I am in Hong Kong now, they don't use ICG at all. They use the dual blue, or the combinations of trypan blue and beryllium blue. And I found it doesn't do the same thing to the IOM as the ICG does. So it makes a little more work to kill the membrane with the blue dye, I think.
And what about the toxic issues on the ICG?
Interesting, because the study done showing the toxicity is to the RPE. And so it could be an issue for the macular hole. But for the cases of ERM, it wouldn't be necessarily be a concern. As I mentioned, in Toronto, they use the ICG dye predominantly, and we haven't seen that at all. I think the difference between what you see in the publications or in the lab and what is seen in real life is that when we put in the ICG dye, we allow it to contact, and then we remove it right away. We don't leave it in the eye for any long period of time. We don't do air fluid exchange to give the contact to have a prolonged contact. So the contact time between the ICG dye and the retinal surface are quite short in the way that we use it. That may be the reason why we don't see the toxicity issues being a problem. I know in quite a number of the American cities, they also use the ICG dye. So, and I haven't seen any case report or no report of toxicity. But I think it's probably to do with the exposure time and the concentration that is used.
I have the same problems. So I'm using the triple blue and the blue together because we used to combine the hair, and for membrane and ILM together. That I'm using first an injection. I wait a little bit, then I do the vitrectomy. I remove the excess paint, and then I go for it, and I'm trying to remove it. And then I stop, because there's no such a clear thing for the first time, and then I re-inject again. Because I've already scratched and pinched and do something, there are some frills around that I can play with. So I don't hesitate to do a second injection in the middle of the ILM removal. And it helps me a lot. The second
I think
is always dying much better than the first.
Yeah, I think it's a good idea to repeat the stain. I think your suggestion is very valid, and I think repeating the stain will get you a better visualizations of the address that you create. Otherwise, it may still be difficult to visualize it. So I do restain without any hesitations.
You always do fluid air exchange before the staining?
I never do.
Never do myself also, never.
Mm-hmm.
I just wait a little. I don't just wash it immediately, just wait a little. The idea, people don't know that brilliant blue and indocyanin blue, whatever the name is, they have different way of acting. The epiretinal membrane goes inside to the epiretinal membrane, the dye, so you remove it. On the ILM, it's just sitting on the top of it, so it's not absorbed. That's why there are two different dyes. So if you know the mechanism, you understand that sometimes when you remove the epiretinal membrane, sometimes you remove the ILM also. It's something like 50% of the eyes that you do epiretinal membrane removal, you got some portion of ILM. In the end, I would like to ask something. I don't want to forget it. I would like to ask Victor to get in touch with the organizers, and if you can send me, if we can share with WeTransfer your video. I really look forward. It's one of the most didactic videos of the silicone oil complications and the way you presented it. If you want to, I'll be happy to, and we can communicate via internet when we show it, so you can explain the same way you did with us. It's an absolutely didactic issue. Thank you very much for showing us. Hudson, are we finished? Because I have my lunch here.
Sure, and now we just finished, you know. We had just a couple of cases left for the next Retinawesome 14. Sasamoto could not show up, as well as André Jucá, so we finished. And because you have, Athanasios, your lunch now, I know you are pretty tired, and it's 11 p.m., I guess, in Hong Kong as well. It's 4 p.m. in Greece, 11 p.m. in Hong Kong. And so I would like...
I have a big body.
I would like, Athanasios, you to say just a couple of words, and we close the event, okay?
Yes.
Have a great weekend, everybody else. And Pablo, thank you. And I see you in the Retinawesome 14. These Retinawesome meetings are getting a little shorter because of the sake of time, so that we could discuss more as we did. I think it's better. Of course, we had these issues today in the sound, and but everything is, you know, we are learning from the pandemics. And thank you, Ashraya, and Natarajan for participating, and everybody else. And I see you in the next Retinawesome. Have a very good Sunday, you all.
Thank you.
Thank you all.
Bye.
Thank you all. See you soon. Bye-bye.
A very good evening, everyone. Good evening, everyone. Hello, Dr. Farhan. Hello, Kangsha. Hello, Nehal. Thank you, Dr. Swati. A very warm welcome to everyone, guys. Thank you, Dr. Amit. Good evening, everyone. Yes. Hello, my dear doctors. A warm welcome to all of you, and a very good evening to all of you guys. Thank you. Good evening, Saddam. Good evening, Kishore. Namaste, Mohit. मैं ठीक हूँ. Hello, sir. Good evening. A very good evening, sir. Yeah. So, hello, my dear doctors. A warm welcome to all of you. First of all, to begin the session with, this is Dr. Azam here, your Faculty of Anatomy. And now, my dear doctors, just keep this here. I'm seeing all your messages here, sir. Yeah. चलिए sir. So, hello, my dear doctors. Warm welcome to all of you here. This is Dr. Azim here, your Faculty of Anatomy. And I'm going to actually now discuss with all of you all the high yield topics of anatomy, which are necessary and which are like must do, should do topics before going to your exam. So all the students who are actually preparing for your MCA exam this January 2024 MCA exam, तो उन सब के लिए ये सेशन बहुत ही important है. And in this session, we are going to cover all the very, very high yield topics. Actually, those topics which you have to learn and go to the exam, sir. Okay, now. Thank you, Sriniket Kumar. Thank you. ठीक है. Now, first of all, to begin this session with here, thank you, Mansoor Alam. Now, to begin this session here, my dear friends, actually, I would like to thank, this is a very good initiative that we have done here right now. Why? Because I think you all know, like recently, like few days back, we also had a YouTube session where they have actually, come up with a very, very nice thing that there is a collaboration between ISM EduTech and the doctortorials. And because of that collaboration, right now, we are able to do this live session on the YouTube channel of Dr. Bhanu Prakash sir. And I would like to thank Dr. Bhanu sir for allowing me and giving me this opportunity to actually come onto this channel here, YouTube channel, and share my knowledge with you people and help the students also. Yes. So with that note, guys, actually it is like a good situation for us. Okay, this collaboration is a very good collaboration here. And now with this one, let's get started right now, sir. Take it. So my dear doctors, this will be like a rapid revision session. And in this session, I'm going to discuss all the very, very high yield topics of neuroanatomy, then head and neck, embryology, upper limb, lower limb. And then I'll be also dealing with thorax, abdomen, pelvis and perineum, like all the topics we are going to discuss like one by one, all the high yield topics we're going to discuss. So is it okay? So without any further ado, let's get started right now, sir. Now, the first topic that we are actually going to begin here will be neuroanatomy, sir. Okay, now. So because you will are like fresh right now, so let's get started with the neuroanatomy first of all. And then we'll be doing like head and neck topics, sir. Then in the middle, just to balance the class, we'll do some easy topic. Then also we're going to do the embryology part, sir. Okay, now. So we are going to actually do all the high yield topics, sir. Are you all with me? Just give me a thumbs up, guys. If you are with me, let's get started right now. So yes, Srilekha, Abhishek, yes, sir. Yes, sir. Okay. Thank you, Chief. Thank you, sir. Actually, the volume, video, everything is actually perfect from our end over here. Yes. My dear friends, why? Because if there is any problem in the volume from here, then obviously it will be the issue for all of them, sir. Okay, no? Thank you, Mohit. Thank you. Chaliye, sir. All good. Let's get started right now. Okay, no? So now the first thing that we are going to discuss, that is about the neuroanatomy topic, sir. Ab main aapko bataunga ki in neuroanatomy, like what are the topics that you have to actually learn for your MCA exam. Okay. Now, my dear doctors, if you are able to see here in this session, the first topic that we are going to discuss is about the sections of the brain, sir. Fine. So number one, we are going to discuss the coronal section, and then we are going to discuss the parietal section as well as the transverse section of the brain, sir. So in this manner, remember, your exam is not going to get completed without these sections in the exam, sir. Your MC exam, your paper will not be completed without the section. So definitely one or two questions will be actually coming from these three sections here, sir. So first, let's get started with the coronal section. And as you can see here in the coronal section itself, we are actually going to discuss about what's the lateral ventricle also. So in this diagram, this one here will be the lateral ventricle, and this is another lateral ventricle. Both the lateral ventricles will open into the third ventricle, sir. With the help of opening, that opening is known as the foramen of Monro. Okay, now. So I would request everyone to like fully concentrate here, sir, for another like couple of hours. Okay, now. Another for a couple of hours, sir. 2-3 घंटे के लिए completely along with me, guys. ठीक है ना? सब लोग मेरे साथ में, forget about everything. Please keep your phone on that, without notification wala mode. Off all your notifications on. Just be with me here, sir. ठीक है ना? Now, so in this diagram, first of all, you're able to see the two lateral ventricles, and the lateral ventricles will open into the third ventricle via foramen of Monro. ठीक है ना? Now, if you're able to see just above the lateral ventricle, अगर आप lateral ventricle के ऊपर देखोगे, there is a bundle of fibers, and this bundle of fibers will be connecting the right half and the left half. Now, I hope all of you know that the right half of the brain and the left half of the brain are connected to each other with the help of commissural fiber, and the largest commissure will be the corpus callosum, sir. So which one will be the largest commissure? That is your corpus callosum. And this one here will be the corpus callosum. And this corpus callosum is actually going to form the roof of the lateral ventricle, sir. So in the diagram, you can very clearly see this is going to form the roof of the lateral ventricle. Now, between the two lateral ventricles, we are able to appreciate one septum here in the middle. And this septum here will be the septum pellucidum. This septum will be the septum pellucidum, sir. And just attached to the lower margin of the septum pellucidum, this one here will be the fornix, sir. And this one is extremely
A gente usa o Monday para tudo, para gerir todos os nossos leads e fazer ali todo o controle de produtividade do time.
Eu vejo a Monday como um elemento integrador dentro da empresa.
Ver onde estão os documentos, toda a parte de feedback, qual equipe está mais sobrecarregada, qual equipe não está.
Uma ferramenta bem colorida, interativa, fácil de utilizar.
Na primeira semana a gente já estava 100% aderente. A gente com certeza dobrou a produtividade.
Os times também começaram a pegar atividades mais complexas para fazer e deixaram as mais simples para automação. Muito feliz com a Monday.
Vamos construir um caminho novo e eficiente juntos com a Monday.com. Comece agora o seu teste gratuito.
Extremely important for your MCI exam, sir. Not only MCI exam, even for other exams also, the phonics is very much important. You should be always able to identify phonics in every section possible, guys. Now, for example, if my hand here is like septum pellucidum, on either side you're having the lateral ventricle, the lower border of the septum pellucidum will be attached with the two fornix like this. So both the fornix are coming here like this. The lower border of that is attached. And these two, that is septum pellucidum and the fornix here, are going to form the medial wall of the lateral ventricle, sir. So septum pellucidum and the fornix are together going to form the medial wall of the lateral ventricle. Perfectly done. Then in this diagram, this one here will be the caudate nucleus here. And then this one here will be the thalamus here. In between the caudate nucleus and thalamus, there is a vein, and this vein here will be the thalamostriate vein, sir. Thalamostriate vein. And yes, you are able to see the network of capillaries over here. And this network of capillaries is nothing but choroid plexus. And all these four structures are going to form the floor of the lateral ventricle, sir. It is going to form the floor of the lateral ventricle. So number one, this one here will be the caudate nucleus. Number two, this one here will be the thalamostriate vein. Thalamostriate vein, sir. And this one here, the network of capillaries here, that is choroid plexus. And this part here will be the thalamus part. So. And all these four parts together, they are going to form the floor of the lateral ventricle. Wow. So in this manner, my dear doctors, in this diagram, we are actually done with the roof here. We are done with the medial wall here. And then we are done with the floor here. Perfectly done, sir. So in this manner, actually, we are actually done with the lateral ventricle, all the boundaries of that. And even the coronal section is also done, sir. If you know these structures in the coronal section, then no need to worry about any other structures, sir. Yes, remaining things you already know very well. The outer part of the brain will be the cerebral cortex, and then from there we'll be having corona radiata, internal capsule. ये तो सब कुछ आपको already पता है, sir. Okay, so I'll just show you here, sir. This outer darker part here of the cerebral hemisphere will be known as the cerebral cortex. And from the cerebral cortex, there will be the fibers starting in the fan-shaped manner, that is corona radiata. And all these fibers will converge together and they're going from here, that is internal capsule. So ये सारी चीजें तो आपको already पता है. That is the reason why I want you to concentrate on these structures here. अगर ये याद हो गया, so that's all, sir. You are done with the coronal section. Perfectly done, sir. ठीक है ना? Is it okay? Fine here? Yeah. So, my dear doctors, let us just revise this once more, and it is worth repeating right now, sir. Come on, tell me. What is going to form the roof of the lateral ventricle? Corpus callosum. The medial wall is formed by septum pellucidum and the fornix. And the floor is actually formed by the fourth structure, the caudate nucleus, thalamostriate vein, choroid plexus, and the thalamus, sir. All these structures are forming the boundaries of the lateral ventricle. Perfectly done. Now here itself, let me tell you like one more point here, my dear friends, about the fornix. I hope you all have learned about the limbic system. The limbic system will be having thalamus and the fornix and the mammillary body and all. So just draw one small diagram here, sir, along with me. So my dear friends, for example, if this one here will be the thalamus, and the thalamus will be continuing into the, hippocampus, and hippocampus will continue into the fornix, and that fornix will go and join with the mammillary body. So hippocampus, and finally it is going and joining with the mammillary body here, sir. So this one here will be the hippocampus, and this one here will be the fornix, and this will actually go and join with the mammillary body, sir. With the mammillary body. And all this will be actually the components of your limbic system only. Okay, now. So there'll be hippocampus and the fornix and the mammillary body. So fine. Now, one important MCQ that you have to learn from here is fornix on one side will be joining with the fornix on the other side. And I just now told you the basics very clearly. Anything like joining the right half of the brain with the left half of the brain will be actually known as your commissural fiber. So obviously it is joining the right fornix with the left fornix. So iska naam kya hona chahiye? What should be this one? This is commissure. But listen very, very carefully. This one will be hippocampal commissure. Which commissure is this one? Hippocampal commissure. But the important point here is that hippocampal commissure connects what? What it is connecting, sir? Remember, it is going to connect the fornix on either side. Please don't mark in the exam as hippocampus. Remember that hippocampal commissure is going to connect fornix on either side, sir. Because क्या होता है, in the exam, 19 subjects will be in your mind. Of course, if you study and go, 19 subjects in the mind with full of tension, anxiety and all. And in the exam, what will happen? Common sense will dominate, sir. On that day, no anatomy, no assumptions, nothing there. On that day, common sense will dominate. And hippocampal commissure connects what's it? Hippocampus. लगा दिया. And फिर result आने के बाद में dash. समझ में आ रहा है? तो इसीलिए please remember that hippocampal commissure connects what's it? Fornix. It is going to connect fornix, not hippocampus. Second point here is that this fornix is going to begin from where? Okay. So remember, I told you the fornix is between the mammillary body and the hippocampus. But you have to remember that the fornix is going to begin from where? So remember, it's going to begin from the hippocampus and it is going towards the mammillary body. Even that was also asked in the exam, sir. So please remember, the fornix is going to begin from hippocampus and it is going towards the mammillary body, sir. Perfectly done. So we are done with the coronal section. Along with that, this part is also discussed. So 2 MCQs here, sir. So about the phonics. Phonics is going to begin from hippocampus, and phonics are connected by what, sir? Hippocampal commissure. 2 important MCQs covered here, sir, in small diagram here. Okay. चलिए अब बढ़ते हैं आगे towards the sagittal section here. Now, again the same thing in this diagram. First of all, you are able to see this largest commissure here. This is corpus callosum. In your MCA exam, once they have asked about the parts of the corpus callosum. In the corpus callosum, you'll be having like 4 parts. This one here will be the rostrum. This bent here will be genu, and this is the body here. And finally, this one here will be the splenium, sir. Again, so there'll be rostrum and the genu, and then there will be a body, and finally you'll be having the splenium. Okay. And now, abhi मैंने आपको बताया था, just now I told you, below the corpus callosum, you're able to see that septum pellucidum here, and below that, the lower margin will be attached to the fornix there. So therefore, my dear doctors, this structure here will be again the same thing. This is fornix. And below the fornix, you'll be having the choroid plexus. This is the choroid plexus. And you can clearly observe here, this one will be the third ventricle. So if this one will be the third ventricle over here, you can clearly see in the diagram here, sir, what is going to form the roof of the third ventricle. The roof of the third ventricle will be formed by fornix and the choroid plexus.
A sensibilidade dos dentes, ela se manifesta como uma dor que causa extremo desconforto. O creme dental Sensodyne, ele age especificamente na sensibilidade e resgata o conforto e a qualidade de vida do paciente. Eu recomendo o Sensodyne porque funciona.
This is going to form the roof. Perfect. Now below the rostrum, this commissure here will be known as the anterior commissure. And below the anterior commissure, there will be lamina terminalis. This one will be the lamina terminalis. And these two are going to form, obviously, the anterior wall of the third ventricle. Then behind, what do you have? How to identify this one? Observe this thing very, very carefully here. Below the splenium ke niche, yes, there will be a gland here. This gland will be known as the pineal gland, sir. That is the important landmark here. First, you identify the pineal gland. And after identifying the pineal gland, this commissure here below the pineal gland will be posterior commissure. And above the pineal gland, you'll be having the habenular commissure, sir. Habenular commissure. And of course, this duct here, everyone knows, guys, this duct is known as the aqueduct of Sylvius, sir. Wow. So please understand the method to identify. पहले आप क्या करोगे? Splenium देखोगे. Splenium तो clearly नजर आएगा. और splenium के बिल्कुल नीचे, below the splenium, there will be pineal gland. और pineal gland के नीचे होता है posterior commissure और उसके ऊपर होता है habenular commissure, sir. And the duct is aqueduct. And we can very clearly see in this diagram here. Yes, my dear friends, all this is going to form which wall of the third ventricle? The posterior wall of the third ventricle, sir. Okay, so we are done with the roof here. We are done with the anterior wall here. And then we are done with the posterior wall here, sir. Wow. So in this manner, very clearly, like crystal clearly, we are done with the boundaries of the third ventricle. The roof is done, anterior wall is done, posterior wall is done. And now welcome to the floor of the third ventricle. That is extremely important. Okay. Now this crossing here is known as the optic chiasma. So this crossing here will be the optic chiasma. Below the frontal lobe here, below the frontal lobe, there'll be eyeball. And from the eyeball, you'll be having optic nerve and optic nerve. Fine. Below the eyeball, there'll be optic nerve. Eyeball will continue behind into optic nerve. And optic nerves will be actually crossing there to form your optic chiasma. Fine. And just behind the optic chiasma, this part will be your infundibulum. And infundibulum will be attached to the pituitary gland below, sir. And this body here, again, the same thing. This is the mammillary body. And this perforated substance here will be the posterior perforated substance. And this part is actually the midbrain wala part. But in midbrain, my dear friends, within few minutes, I'll show you here. जो aqueduct होता है ना, aqueduct is an important landmark. Why? Because whatever part that you find behind the aqueduct, that will be the tectum part, And in front of the aqueduct, this part here will be the tegmentum part. To be more specific, it is the tegmentum part of the midbrain, sir. And all these structures are going to form the floor of the third ventricle. Wow. Are you understanding me here? तो एक बार दोबारा repeat करते हैं, sir. It is worth repeating. And in the ventricles nerve, the floor are very much important, sir. So first of all, you'll be having optic chiasma. Just behind the optic chiasma, there'll be infundibulum. Then behind that, there will be mammillary body. Then there'll be posterior perforated substance. And then there'll be tegmentum part of the midbrain. All this together, they are going to form the floor of the third ventricle. Okay, that's all. Now, in this diagram of sagittal section, if you know these structures, my dear friends, that's all. That's all. For any exam, you're ready. Why? Because the remaining things to humko padhne ka zarurat hi nahi hai. This is midbrain here. And this one will be actually the pons here. And this will be the medulla here. And this one will be the cerebellum here, sir. And if this is the hindbrain, this ventricle here will be the fourth ventricle. Ye to matlab sabko pata hai. Even a first year MBBS student knows this very well, sir. Understanding your point here? So these are the structures you have to know, sir. So by this, we are done with the coronal section and the sagittal section. Now in this session, let's have an integration between anatomy as well as the radiology also. Why? Because nowadays, you know very well how they're asking the questions. Hai na? They are actually integrating like images given in the radiological format, but the question will be actually anatomy question only. So let us try to identify the same thing here also. So abhi jo humne yahan par padha hai, so let's have a comparison with the radiological image right now, my dear friends. Now in this image, you can clearly see this structure here will be what here, sir? This one will be the corpus callosum. Just below the corpus callosum, this one here will be the fornix. Wow. And this ventricle here obviously will be the third ventricle here, sir. And try to identify this one here is aqueduct. So aqueduct ke piche wala jo part hota hai, that is your tectum part. And this is actually the tegmentum part. And please try to identify this body. This body will be the mammillary body here. This gland here will be the pituitary gland there. And this is the infundibulum of the pituitary gland. In front of that, this is optic chiasma. So I hope you are able to identify all these structures over here, sir. Is it okay? Perfectly done. So in this manner, we are done with yeah. Hello, my dear friends. Actually, I got a call from the technical team that like some people are actually commenting there regarding the brightness here. I'm taking the class. Whatever I'm writing here on the iPad, it is completely like full brightness here. And even which is being relayed from here on the MacBook here, it's like full brightness, like completely like from here, there is no issue at all. It is completely like full of brightness here. Okay, na? Chaliye. So fine, let's not actually get disturbed with all these things here, sir. Fine. So there is a coronal section here and the sagittal section. Both are done, sir. Yes, Pushpendra Singh is telling all normal, sir. Everything seems okay on the screen, sir. Yes. Actually, our online classes, man, it will be like very nice. Why? Because I'll be telling you my experience. If there is any problem from my side now, if there is any problem from my side or our side, from our technical team side, then it will be a problem for all the students. अगर मेरी आवाज नहीं आ रही तो सबको नहीं आ रही है. So it is easily identifiable in the chat, chat box that सबको issue होगा. अगर 1 or 2 or 3, 4 people are messaging there, it means that they are having the issue at their end. So please try to check your internet there. You should have a proper Wi-Fi there, because the Wi-Fi has to be like the high-speed Wi-Fi from both the ends, from my end as well as your end, and from my end it's like perfectly fine. Thank you, Ji. Continue, sir. Thank you, sir. Everything is good, sir. No problem, sir. Yeah, that's what I'm just trying to clarify for the others. So it's not a problem from my end. If there is a problem from my end, it will be for everyone. It will be for everyone. Okay, no? Thank you, Ji. आगे बढ़ते हैं, sir. Now let us go ahead with the transverse section right now, sir. So we are done with the coronal section. We are done with the sagittal section. Now let us learn about the transverse section of the cerebrum. Fine. Now, in the transverse section of cerebrum here, there will be caudate nucleus here, sir. This will be thalamus here. And this one here will be the lentiform nucleus. Very much important for your MCA exam, sir. Many a times in your MCA exam, they have given an image, and even the radiological image was also given there, sir. And they have given an arrow mark here, and you have to identify that nucleus. And that nucleus is clearly identifiable. That is lens-shaped nucleus, lentiform nucleus there, guys. Okay, now, after that, the caudate nucleus, thalamus, and lentiform. In between them, you'll be able to find this bundle of fibers here. This is nothing but your internal capsule. What is that one? Internal capsule. Fine. So now let us discuss about this internal capsule in detail here, sir. In your MCA exam, they're asking a lot of questions regarding this one. So let us discuss about the internal capsule here, sir. Fine. Now, for example, if this one here will be the internal capsule here, sir. First of all, the relations of this one. What do you have on the lateral side of the internal capsule? That is lentiform nucleus. What do you have on the medial side? On the medial side, there will be caudate nucleus. And then here, you'll be actually having the thalamus, sir. So on the lateral side, there'll be lentiform nucleus. And on the medial side, we'll be having caudate and thalamus. Perfectly done. Take it now. Then after that, how many parts are there? Relations are done. Relations are done. And now the parts. There are totally 5 parts in the internal capsule here. This limb will be the anterior limb. The bent in the middle will be genu. And this limb here will be the posterior limb, sir. But the important concept here is that the posterior limb kahan tak hota hai, sir? The posterior limb will be up to where? So remember, till wherever you actually have your lentiform nucleus, till there will be the posterior limb. That is a landmark. So the posterior limb will be up to the lentiform nucleus. Then whatever part you have behind the lentiform, retrolentiform, below the lentiform, sublentiform. So in this manner, internal capsule will have totally 5 parts, sir. Anterior limb, the genu, the posterior limb, retrolentiform part, and the sublentiform part. Sublentiform part, sir. Take it now. Now the important thing here is what are the tracts which are going to pass from here? So number 1, there is a tract passing through genu part, and that tract will be corticonuclear tract, sir. So corticonuclear tract is passing from which part of the internal capsule? Genu part, sir. Corticonuclear tract is passing through which part, sir? Genu part. Then there is one more tract passing from here, your favorite one, that is corticospinal tract, sir. And corticospinal tract is also known as pyramidal tract. Pyramidal tract, sir, the very famous one. And it is passing from anterior to third. Ye yaad rakhna bahut important hai. Anterior to third of which limb? Posterior limb. Posterior limb to sabko pata hota hai. Even first year MBBS student will also be knowing it is passing through posterior limb only. Lekin kahan se? Anterior to third of the posterior limb, sir. Anterior to third of the posterior limb. Are you all perfect with this one here? So please remember about these 2 tracts here, sir. From the genu, there will be corticonuclear tract, and from the anterior 2/3 of the posterior limb, there will be corticospinal tract, sir. Okay, now, now, my dear doctors, let me just add one more point over here, sir. I hope you all have heard about the geniculate body, sir. There will be a lateral geniculate body, and then there will be a medial geniculate body, sir. On the lateral side, lateral geniculate body, and on the medial side, medial geniculate body. And I think all of you have heard about these 2 geniculate bodies, and they come in the visual pathway and the auditory pathway also. Lateral geniculate body, please remember that L for lateral, L for light. So lateral geniculate body comes under visual pathway. Medial geniculate body, remember M for medial geniculate body and M for music. And that comes in the auditory pathway, sir. Wow. This is how things become easier right now. So L for light, L for lateral geniculate body, M for music, M for medial geniculate body. That comes in the auditory pathway. Now from the lateral geniculate body, whatever fibers are going to begin, these fibers are going to pass through the retrolentiform part. From the lateral geniculate body, optic radiations are going to begin, and they are going to pass through which parts, sir? Retrolentiform parts. So this radiation here will be referred to as optic radiation. And obviously, optic radiation will be going to which area? It will be going to the visual cortex. And what is the number of the visual cortex? Area number 17, 18, and 19, sir. Wow. So therefore, optic radiation is going through which part? Retrolentiform part. Okay, ji, done. Medial geniculate body, I told you it is actually coming under which pathway? Auditory pathway. And from here, there will be obviously auditory radiation. And auditory radiation will be going to pass through the sublentiform part, sir. So this radiation here will be the auditory radiation. And this auditory radiation is going to pass through sublentiform part. और ये कहाँ जाएगा? Obviously, this will be going to the auditory area, and that is area number 41 and 42. Or important thing, in the exam, they have given the name of this gyrus here. This is also known as the Hessel's gyrus also. इसको हम Hessel's gyrus भी कहते हैं, sir. Understanding point here, guys? So therefore, remember, auditory radiation is going to pass through which part, sir? Sublentiform part. Fine here. So please remember in this manner, L for light, L for lateral geniculate body. So lateral geniculate body will come under which pathway? It will come under visual pathway. So automatically you will be getting the remaining answers. Obviously, अगर वो visual pathway होगा, तो optic radiation होंगे. They'll be going to which area? Visual area. And then medial geniculate body, remember M for medial geniculate body, and remember M for music, auditory pathway. So कौन सा radiation होगा? Auditory radiation. That will go to which area? Auditory area. And of course, they have asked in the exam about the Hessel's gyrus also, sir. Understanding? So in this manner, what I have completed here is all the tracts which are passing through which part of the internal capsule. So let us do it once more here, sir. It is worth repeating. Number one, corticonuclear tract is passing from genu part. Number two, corticospinal tract is passing from anterior 2/3 of the posterior limb. Similarly, optic radiations are passing from retrolentiform part. Similarly, auditory radiations are going to pass from the sublentiform parts. So each and every part, which radiations or which tract is passing, we have completed, sir. And not only that, if you are observing my diagram very carefully here, sir, in this rapid revision session, in one diagram, we are actually done with like all the points regarding internal capsule, sir. So internal capsule,
Quero isso. Ter meu próprio negócio. Uma mulher. Por trás de tudo.
आपको पता चल गया है? You know the parts of the internal capsule there itself. You know the relations of that one, lateral and medial relations of this one, and then you're also done with the tracts here, sir. So many points regarding the internal capsule has been completed here, sir, in a simple manner. Okay. चलिए आगे बढ़ते हैं, sir. Let's go ahead right now. Now, after completing about these three sections here, hello, my dear doctors. After completing about these three sections here, now I can guarantee you that definitely 1 or 2 marks you can easily solve in the MC exam. So definitely you'll be getting like 1 or 2 marks in the MC exam. Because exam will not be completed without these three sections. So you have to be like perfect with the coronal section and the sagittal section and the transverse section, sir. So all the sections should be perfectly done, sir. Okay. Next one. After that, another important topic for your MC exam is spinal cord, sir. Or spinal cord, you don't have to worry about everything there. I'll just tell you what to learn. Extent of the spinal cord is extremely important for your MC exam, sir. Now, in the extent, first of all, in adults. In adults, spinal cord will be extending from C1 to L1. L1, which border, sir? The lower border of L1. Then in the neonates, it will be from C1 to L3. L3, which border? The upper border of L3. So first, you remember about the extent of the spinal cord. In adults, C1 to L1, and in the neonates, it will be from C1 to L3. After that, I want you to just remember the ending part of the spinal cord, sir, the last part. Okay. Now, in the ending part of the spinal cord, I hope you all know that the spinal cord will end in a cone-shaped structure. And that cone-shaped structure will be referred to as conus medullaris. Spinal cord ends in a cone-shaped structure, conus medullaris. और अभी मैंने आपको बताया था कि spinal cord end कहाँ पर होता है sir? It is ending at the level of L1. At the level of L1, sir. Then after L1, what do you have? In the remaining lumbar and the sacral and the coccyx, up to coccyx, what do you have there? So remember, there will be a fine thread-like structure all the way going up to coccyx. And this fine thread-like structure is known as phylum terminale. Now, what is this phylum terminale? Remember, it is the modification of your pia mater. So what is the innermost meninge here? Pia mater. And pia mater is not going to stop here. That will continue down. And that continuation of the pia mater itself is nothing but the phylum terminale. So pia mater itself will continue down to form your phylum terminale. Now automatically, what is the next doubt in my mind? अगर ये pia mater है, तो फिर arachnoid and dura कहाँ है? So arachnoid and dura mater are going to descend down and join with the pia mater. Arachnoid and dura mater will descend down and join with the pia mater. So you imagine this blue colored line here to be the arachnoid matter as well as the dura mater here, sir. Okay. Now, the first point that you have to learn is where is this arachnoid and dura mater joining? It is joining at the level of S2, sir. Remember, spinal cord is ending at L1, but arachnoid and dura mater, it is going to join at the level of LS2. Now, if there are like three meninges, how many spaces do you have, sir? Now, between the dura mater and the arachnoid mater, there will be subdural space. And between the arachnoid mater and the pia mater, there will be subarachnoid space. So now if this is arachnoid here and the pia mater here, what is the space here, sir? ये space जो होती है इसको हम कहते हैं subarachnoid space. और यहाँ पर क्या होता है? What do you have in the subarachnoid space? CSF होता है. That is the reason why you will be able to do the lumbar puncture here. And lumbar puncture is most commonly done between L3 and L4, sir. Perfectly done. So spinal cord will end at the level of L1 and we can do the lumbar puncture at the level of L3 and L4, between L3 and L4. Why? Because yes, here the spinal cord will not be damaged. So, understanding? So there are like so many MCQs here, you have to remember them. So let us just repeat this once more here. The spinal cord ends in a cone-shaped structure, conus medullaris. From there, there is a fine thread-like structure, phylum terminale. Phylum terminale itself is a modification of pia mater. It's a modification of what's a pia mater. Arachnoid and dura is meeting at the level of S2. So therefore, we can do the lumbar puncture at the level of L3 and L4. So between L3 and L4, you can do this. Okay, now? Are you understanding me, sir? So in the in the spinal cord topic, sir, these two things you have to learn. That's all. That is more than enough. So the extent of the spinal cord, after that, the ending part here. And please, my dear friends, no need of, wasting your time in learning silly things like what is the shape of the spinal cord, it is cylindrical, what is the, length of the spinal cord and all. All those things are not asked nowadays in your exam. So agar ye do topics pad loge aap, that's also, it is done. Okay, now, this is about the revision of the spinal cord topic here, sir. Now, after this one, let us move on to the next topic, that is brainstem. And I want all my dear students to please pay attention here right now. 200% concentration here, sir. Why? Because now we are going to start with brainstem. And in brainstem topics, sir, there will be a definite question in your MC exam, guaranteed, sir. I'm not even telling expected here. I'm telling you pakka question, definite question. मतलब सवाल आना ही आना है यहाँ से, एक सवाल पक्का आना है सर ब्रेनस्टेम से, ठीक है ना? Now, I cleared FMG exam, but still came to see Dr. Azam, sir. Thank you, Dr. Jamal. God bless you with a lot of success. Sir, please take biochem revision also. Yes, Ayush Jain, no problem with that one. Cleared my FMG 2020, but still came to love your way of teaching here. So thank you. Crumpled paper. Wow, what a name. Now, my dear friends, welcome here. Let's get started right now, sir. Ab start karte hain. In the brainstem, first of all, this one here will be your midbrain. And this big structure here will be the pons. And this one will be the medulla oblongata, sir. So there will be midbrain, pons, and the medulla. Now the first thing that you have to understand here is that how many cranial nerves are going to begin from the brainstem? 3 to 12. How many cranial nerves are going to begin? 3 to 12, sir. So from the midbrain, there will be third nerve here. And this one here will be the fourth nerve here, sir. So from the midbrain, there will be third nerve and the fourth nerve. And please appreciate in this diagram here itself, sir, the fourth nerve is the only cranial nerve which is having dorsal origin. That is the reason why you can clearly see here, it's originating dorsally, then taking a turn and then coming in the front, sir. Understanding? So third and fourth nerve is going to begin from midbrain. And remember, the fourth nerve is the only cranial nerve having dorsal origin. It will take a turn and then come in the front there. You can clearly appreciate in our diagram. Acha, क्योंकि ये इतना घूम कर आ रही है, it's taking a turn and coming in the front. That is why it will be having the longest course. It is having the longest intracranial course. So fourth nerve is the one which will be having the longest intracranial course. And then one more point, if you want to remember here, my dear friends, remember that the fourth nerve will also have internal decussation. Now, by the way, what is the meaning of decussation here, sir? What is the meaning of decussation in your anatomy? Remember, decussation means crossing. So please आप वहां पर ना कहीं पर लिख लीजिए, write down yourself there itself, in the corner of the page. Decussation means what? Crossing. Crossing. And remember, the fourth nerve is actually going to cross inside the midbrain only. That's the reason why అందుకోసం దాన్ని internal decussation అంటారు. That is the reason why it is known as internal decussation. It's crossing inside the midbrain. After crossing inside the midbrain, then it is actually coming out, sir. Then coming out. Okay, fine here. Badhiya. Now this one will be the pons, and from the pons you can clearly see this nerve coming out here. This will be the fifth nerve, sir. That is your trigeminal nerve. Trigeminal nerve is coming out from the pons. And to be very, very specific here, sir, to be very specific here, this one will be actually the pons here. And this pons is going to join with the cerebellum behind with the help of this peduncle that you are able to see here, sir. And that peduncle is known as the middle cerebellar peduncle. What is this peduncle here, sir? Middle cerebellar peduncle. So therefore, my dear doctors, remember very carefully, fifth nerve is exactly coming out at the junction of pons and the middle cerebellar peduncle. So don't just say only it is coming out from the pons. To be very, very specific, fifth nerve kahan se aa rahi hai, sir? Fifth nerve is going to come out from the junction of pons and the middle cerebellar peduncle, not cerebral, cerebellar peduncle. ठीक है ना? अब यार ये तो सबको पता है, अगर pons और medulla होगा, this junction will be the pontomedullary junction. And right at the pontomedullary junction, you can clearly see here, this is the cranial nerve number 6, and then the cranial nerve number 7, and the cranial nerve number 8. So the 6th and 7th and 8th nerve will be coming out at the pontomedullary junction, sir. Coming out at the pontomedullary junction. ठीक है ना? Exactly in the middle here, there will be sulcus. और अगर यहाँ sulcus होगा, on either side will be having elevation. This elevation is known as the pyramid here and the pyramid here. And this is olive and olive here, sir. Now, just lateral to the olive here, there will be 9th nerve and the 10th nerve and 11th nerve coming out. So 9th, 10th and 11th will be originating or coming out lateral to pyramid. And between the pyramid and olive, this will be the 12th nerve, sir. 12th nerve, your hypoglossal nerve will be coming out between the pyramid and olive, sir. Are you getting the clarity now? So let me even write down the full form here, sir. This elevation here will be known as olive, and this elevation here will be known as the pyramid, sir. Lovely. Are you understanding me? So in this manner, my dear friends, first of all, let me just revise this again for you people here. Okay, how many cranial nerves are going to be originating from the brainstem? How many, cranial nerves are going to begin from the brainstem? Yes, 3 to 12, and hence it is proved here, sir. So third and fourth nerve is going to begin from midbrain. Fifth is coming out between the pons and the middle cerebellar peduncle. And 6th, 7th, and 8th will be coming out between the pontomedullary junction. And then 9, 10, 11 lateral to the olive. And then 12th is going to come out between the pyramid and olive, sir. 12th is coming out between pyramid and olive, sir. Take it now. Next one. Now, after this, my dear friends, you also have to remember कि यार ये olive form क्यों होता है? Why this olive is elevated there? Remember, अगर मान लो कि like my hand here is like olive here, sir. This is like elevation here. If you have to see just inside that one, just beneath that one. If you see beneath that one, there will be actually the inferior olivary nucleus. Which nucleus? Inferior olivary nucleus there is. And because of that nucleus, it will be elevated on the surface there. Okay. And the pyramid will be actually